All right, so we have a short list today. One, in 1111, we have Erica Crummy. She is now at G7P2132. She is post-op day 1 from a D&E after presenting with pre-viable PPROM with the cerclage in place. She was 21 weeks and 5 days about. She had 2 prior full-term vaginal deliveries, was told that she had like a short cervix in a prior pregnancy, and so but ultimately delivered full term. And then this pregnancy, she at Lankenau was seen at 16 weeks with like vaginal discharge and pressure was like dilated to like a half centimeter to 1 centimeter, and they placed a cerclage there, and then unfortunately PPROM'd at 21 weeks, and then yesterday. So she's doing well overall, but is going to go home later today.
What MFMs do cerclages on the mainland, do you know?
It was a generalist, I think, who did the
generalist do it?
Yeah.
The generalists do them.
Okay.
And then the rescue ones or physical exam indicated ones are done by like 2 or 3. Katie does them.
Okay.
Caitlin Edelson does them. Everyone.
Okay.
Some of the partners that have been there, most of the partners that have been there for a while don't do them anymore.
Okay. Like Sarah, maybe.
I think Sarah does them anymore.
All right, so the next patient, Stephanie Medley, as we probably, Dr. Bender had kind of sent her in last week. And she's a 40-year-old. She's now a G1P0101 at post-op day 2 from a prime section at 23 weeks in the setting of worsening superimposed severe preeclampsia. As you all remember, she was like diagnosed, I think, with early severe preeclampsia, like based on like rapid up titration of her blood pressure medications. And like by the time of admission, she was already on nifedipine, labetalol, and hydrol. And then the baby was FGR less than the first percentile, had persistent absent diastolic flow, as well as intermittent reversed. So we admitted her last week, gave her beta. And then over the weekend, her blood pressures continued to increase, and then she was maxed out on all her medications.
Three
medications. Yeah, exactly. And then so at that point, this was on Tuesday, I believe. Yes, Tuesday when Sonia was on. They decided to deliver her because of that. Overall, the C-section was classical, complicated by postpartum hemorrhage, secondary to surgical blood loss. The baby apparently, was 310 grams. So
310?
310, yeah, grams.
It
So
was estimated 340, something like that.
yeah. I tried looking at the notes. It sounds like, obviously with the 310 gram baby, the prognosis is probably not that great.
And we'll have neonatology join us a little bit, later on.
Yeah.
We can ask.
Yeah. I think she herself, she had been extensively counseled throughout this entire process, like with ultrasounds and on admission about kind of our concern about the prognosis. But I think right now it's just starting to kind of hit her, like the enormity of having this like extremely premature baby in the NICU. So from a like preeclampsia perspective, after delivery, her blood pressures dropped, and so we took off the hydrol. We decreased the Procardia. So right now she's on Procardia 60 and labetalol 800 TID, and I think her blood pressures have been okay.
Wow.
So it seems like like pretty convincing for
she had the classic preeclampsia FGR combination.
Her labs, there was just like a mild ASD ALT bump, but otherwise they've normalized since delivery. Anything, what else?
She was at very, very high risk for stillbirth, with the intermittent reverse flow, the strip. So, she from day one, she wanted everything done, so I think she got what she wanted, like you say, it hits you more, now that her baby's out, but I think, in terms of OB, MFM management, steroid timing was perfect, so it's as good as a difficult pregnancy like this could have gone.
I can talk about like the surgical case a little bit because I was there. For me personally, this was the smallest baby that I have ever delivered. I did the case with Ari, one of the chiefs, and she did a really great job delivering the baby in call. The
That's
placenta,
good.
yeah, the placenta, as you can expect, came out like it was just a very unhealthy looking placenta. It didn't come out completely intact, which goes along with the picture as well.
What's a comment from Amanda?
Smallest ever baby delivered alive.
Wow.
Dr. Roman.
She said it's the smallest baby delivered alive. Was it intubatable?
Yeah, they were able to. I think they had originally some trouble intubating, but ultimately they were able to intubate. Yeah.
Yeah, I'm just looking at the baby's chart and it's still alive. They did look like they had made 4 or 5 attempts to intubate initially and ultimately were able to successfully intubate the baby when it was 13 minutes old.
Yeah.
What just curious, not to put you on the spot, what the pH was given the strip?
I actually don't know the pH off the top of my head, but I'll have to look it up. I think Apgars were 2 and 6.
That's good.
The baby was moving when we delivered, had good color. But yeah, I would have to look up the pH. I can log on. Or you're logged on, right?
Yeah.
Yeah, okay.
The first gas that I see, I don't know if this was on the umbilical line or actually on the cord, was 726.
Yeah, I don't think it says collected, but I don't know if it's sent or I don't know. It says,
No, just more because it was delivered
Yeah.
because of the strip getting worse. So I was just curious.
We didn't deliver because the strip was getting worse. We delivered because she had been maxed out on 3 of the meds.
Also, right, it's true.
Required more IV pushes after.
Yeah.
We just decided to move forward.
And she
But
got every pushes almost every day. She was in the hospital, the 4 or 5 days before delivery.
yeah. The strip from when I was there up till delivery was baseline. It wasn't great, but it was baseline.
Okay. Thank you.
the next patient is Malika Davis. She is a 34-year-old now postpartum day 1 from a uncomplicated vaginal delivery. Initially was admitted for MMT stabilization. Overall, she is doing well. She's stable on a methadone dose of 130 milligrams. And the plan is to go home today. And then Alicia Wyatt is a patient that was added on to the MFM service, for continuity purposes. So she was 31-year-old. She's now postpartum day 1 from an SVD of twin A and a stat C-section of twin B at 36 weeks and 1 day. She was, and Sonia, you can probably talk more about her, but Sonia spent like the whole day on Tuesday talking to her. She had come in with like no prenatal care. The plan was for like herself, like for a home birth. Like she wanted to have a home birth. I guess she didn't really have a conception of how kind of, twin births would go. She came in for a rule out preterm labor, was not in preterm labor, but had an extensive discussion by our team kind of about because she was initially refusing C-section for any reason. And then and I think Dr. Bolik had texted about her in the group, but baby A was like 11th percentile and baby B was had a 25% discordance and transverse. And so there was a discussion of whether or not people would offer breech extraction, et cetera. Ultimately, she had a vaginal delivery of twin A, and then the baby B,
A was vertex.
A was vertex.
Uh-huh.
Baby B flipped from transverse to breech, and then She did not want an epidural, so she never had an epidural, and they talked to her about doing an ECV to try to flip B to cephalic, which that she was, accepting of. However, she was in a lot of pain. It was difficult to do the ECV. It failed. Baby was bradying to the 50s. So then she ended up getting a stat C-section of baby B, which, we were discussing and debriefing, this entire scenario, and it's kind of difficult to compact all of the conversations that should go into like all the prenatal visits into one admission, because that's what Sonia did essentially, in addition to delivering 1120. But yeah, so she's just on our service for continuity purposes, and yeah.
Yeah, so that was basically the gist of the story. I think this patient had a lot of distrust for medical care. She was planning on a home birth with twins, and that's why she never got any prenatal care. Like Eileen said initially, when she came in, she refused to sign any consents, including the anesthesia consent. So the next day when we came back on, we just tried to talk to her throughout the day and just talk to her about any and all interventions that would be done and see if she would be okay with it. And then thankfully, throughout the conversation, she did end up being a little bit more amenable to what we were recommending. Risk management was involved as well. They got their legal counsel involved, so they were aware of the situation. They were really helpful in case anybody needs their assistance in the future. But I'm glad she's delivered, and I'm glad the babies are.
I don't know if Ruksha's logged in. I think if I probably would have offered this patient a breech extraction. It does not sound like the provider who was in the delivery room offered her that. And whether that's because she was unanesthetized or the patient or the provider felt uncomfortable or the patient declined, I don't actually know. But it does not sound like that was attempted. And I think that I know Rupsha and I spoke about this last night, that Rupsha feels pretty upset that she was in a cerclage when this was happening, and because I think she also is wondering if we could have spared her this cesarean section in some way if it had been a different person present.
Yeah, I think
I'm just coming in at the tail end here. Are we talking about the twins?
Yeah.
Yeah. I do feel bad about exactly what Whitney said. I think it's hard. I wouldn't have done a breech extraction myself because of my limited experience. And I haven't used pipers since like residency or simulation. And so actually, I never actually used pipers on a live birth in my life. And the attending on was not comfortable doing a breech extraction. So it was not, so I think, if she had had a different like OB physician team, I think it would have been different. She knew going in that depending on who was on, they may or may not be comfortable doing a breech extraction.
the other thing from the debrief was that it sounded like she could not even tolerate it.
Yeah, I was going to say the other thing was that she actually tried to examine her and she couldn't tolerate an exam. So that would have made a breech extraction difficult. And, you could have still had a bradycardia as well. Those things might have happened regardless. It was a monodi pregnancy.
Yeah, I feel like either if she had an epidural or even if she didn't, but was like mentally prepared or for kind of the maneuvers and everything, that maybe, but
So I had extensively counseled her on, breech extraction, the maneuvers that would need to be done. So I think she was counseled. She just still did not want any neuraxial anesthesia.
How was
So she
the
did the first baby without anesthesia.
yeah.
how is the baby with the bradycardia doing?
With
The second one.
baby. Oh,
I think the babies are in the room with her.
yeah.
Okay, that's perfect. Yeah, I think we have, you shouldn't feel guilty, Upsha, Whitney, What shall we do? You guys killed yourself for this patient, counseled her extensively, and sure, yeah, we could have saved her a C-section, but also the outcome could have been worse if she was resisting the internal version, yeah.
Mhm.
So you guys worked so hard on this case. Thank you.
Just for academic reasons, to look at the data. So, there is this large twin randomized trial, vertex, non-vertex, and the one randomized to adjuvant delivery did just as well as the C-section. And then, historically, if you look, so you deliver the first baby vertex and you have a non-vertex second twin, there are some retrospective data that compare doing a virgin versus a breech extraction. And some of the data say that if you can do the breech extraction, that may be safer. And I've seen in my, few decades here of like, at the beginning, 30 years ago, probably people were doing more breech extraction. Then for a while, they were doing more virgins. But eventually, I think if you can do a breech extraction, that's probably the way to go. Was the D-cell part of the attempt at diversion, or the attempt at diversion was never done? Was it like a spontaneous
It
D-cell?
was a spontaneous.
Spontaneous D-cell.
Yeah. And they attempted the version and then
After that, they failed attempt.
and then the baby was still breathing
Yeah.
in the 50s. Because I
Okay.
think the patient wanted another attempt, but they were just like, we can't.
Right, we need to.
Baby, so.
Yeah. And usually second babies, like 60-70% of the time, are smaller than first baby. So this is an unusual case that you have a bigger, non-vertex second twin, makes it a little bit.
This one was smaller also. It had been estimated larger on ultrasound, but was actually 12 ounces smaller.
Oh, really?
But no, it was bigger than baby
Oh, I thought
A.
you told me smaller, Rupsha. Sorry.
No, it was smaller than estimated on ultrasound, but
still
larger than
bigger.
baby A.
Got it.
Little larger by like about a pound.
About a pound. Yeah, I mean, that's
Yeah.
the difference.
And I
It
did
was
her
still a
growth.
pound different, but not a pound and a half, I guess, was the.
Yeah, I did her growth, and I will say it was extremely limited, given her body habitus and yeah, just
I mean, the accuracy of a 35-week growth ultrasound is always going to not be great.
yeah.
That was everyone.
We had an unusual case I just wanted to bring up, and others can chime in. Not too MFM or complicated, but we had this 33-weeker Rodriguez. Who do you want to talk about her real quick?
Yeah. Wasn't here over the weekend, but I saw that she delivered. But
Yeah.
we talked about her last week, but she had presented around 33 weeks and change with initially contractions, was ruled out preterm labor. We did cervical lengths, they were consistently 2.5 without any change. So we had a rule, we had discussed with her the likelihood of preterm labor was low and discharged her. She came back mainly with like a little bit more spotting, like vaginal spotting and bleeding. And because of that and ongoing contractions, we started to think maybe this was more of a placental eruption type picture. So we gave her beta. She ultimately kind of stayed through the entire week. And then I think over the weekend became more uncomfortable and had made change from, she was always like 1 centimeter and then made change to 2.5. And then ultimately she was AROM'd and then it sounds like it was bloody fluid and then baby's doing fine last I checked. And so, I don't know what the ultimate placenta looked like, or we'll have to look into the pathology and things like that, but it sounded like a mix of eruption leading to preterm labor situation.
Yeah, to me, it was difficult to manage because I think for 5 days, she had this every 2-minute contractions, off and on, not the whole time, but off and on. She was remitted twice, because at the beginning, we would send her home and she would come back, send her home, come back. And it was just difficult to manage because at some point she was getting morphine as well. We met her the whole weekend, but then she was 34 and 0, 34 and 1. I'm like, doing here? You know, at what time are you giving so much morphine and gabapentin? And, you know, her mom wanted her to be delivered when she presented, her husband did not. You know, they obviously were nervous, and you know, thank God they kind of follow what we suggested. And I think the night between Sunday and Monday, you know, she went through labor and delivered at 5 o'clock on Monday. So it's just unusual, you know. Kind of,
Yeah. I mean, my question was like counseling for future pregnancies. Like, would you consider this as a abruption picture versus like a preterm labor? Because that's kind of
I think that could you real quick look at her? I don't know if you could find her. And I wasn't at delivery because again, this happened Monday morning. But I think it'd be important also for counseling to, you know, she never spiked the fever. She had a soft belly in between contractions. And I'm very happy she delivered vaginally. I think that worked well. But
So this is really a great teaching case for the fellows. And you said she had bloody fluid. So bloody fluid equals abruption.
yeah.
And you did mention when you presented her last week that her baseline contraction intensity was elevated. So she really have, you know, some signs for abruption.
yeah, she looked like
Yeah.
an abruption at some point, like, you know, in terms of pain, frequency. But, you know, she was 33 plus, you know, do you deliver her with a reassuring strip? The strip was always very reassuring.
Yes, they usually pronounce themselves, and this is exactly what happened. So I'm glad you're in the hospital.
So bloody fluid when they ruptured her?
Bloody fluid, yeah.
Maybe it was like 6 pounds, 3 ounces, I think I looked at. So it was big. And again, it's doing well. Other hints of anything? Okay. Anything else? No, all good. Outpatient or
Scan.
scan?
I also have a bunch of scans from Jersey. Go ahead, Kavisha.
So this is a patient who came in from Einstein for a KCL injection last Thursday in the setting at 22 and 1. She was diagnosed with cloacal atrophy.
Yeah.
So I know we don't get to see this often, so I just want to share some of these imaging. At the hospital where she had initially been seen, which was Einstein Montgomery, they had, you know, noted essentially ventral, like midline ventral defect, but they had also noted a sacral spine defect, which we weren't able to visualize because of limited fluid. But I'm just going to go through some of these pictures. This right here is just a transverse view of the abdomen. You can see level of the ACI, a protrusion here. And you can continue to see that it's, again, very difficult to actually see a lot of these things because, just because there is baby's position, but then also really the low fluid made it a little bit difficult to visualize. But here's a video that Shannon had taken. And you can see, like, you know, this protrusion is lower in the pelvis or lower in the abdomen, which you expect to see. The other key thing that you're not seeing here, and we didn't see at all, is bladder visualization. And so that's, you know, one of the hallmarks of a cloacal exstrophy, in addition to also protrusion of the bowels. Let me try to see. Again, this is, I know, horrible imaging, but This was at the thorax, she's going down. This is the attempt at the spine, but again, we're very, very limited. Baby it was essentially like curled up in a ball. So we're not actually visualizing a sacral defect. Eileen, did you ever get to see them? Did you?
Sounds like she was primarily managed by one of the residents, Snorri. Yeah.
She wrote it. I'll show the notes too. But again, we're not able to really see any defect of the spine. So I'm just going to skip forward to these. Again, kind of limited, but here's another transverse view. And this is just with color to show where the location of also. Again, we're not seeing the bladder at all.
Transverse at the ACI.
ACI. Again, another view demonstrating the same thing.
And it looked like there was like a cyst in the spine, right?
Hard to say if that was just artifact or not. Yeah, we really couldn't see anything. The patient had essentially presented for a KCL injection. After I spoke to her, she ultimately declined KCL and just wanted delivery. She was 22 and 1, so we had to talk to L&D to see if that was okay with staff. She ultimately underwent an induction, delivered, and I'll pull up the patient declined us being allowed to take pictures of the fetus, unfortunately. Eileen had asked, and the patient said no, but in terms of the report, there was no sacral defect that was seen. There was a non-patent anus, which is important to know. And then also, based on like the wording, it does seem to be like the classical elephant sign that's reported or typically seen with the cloacal exstrophy. I know we couldn't see that here, which is why I prepared a few slides on this, because again, I don't think we see this very often. And so
just a quick comment as you bring them up. I may have circulated, I think from family planning on, doing a filicide, before termination or not. And the fact that it was basically a guideline with SMFM saying that in general, it doesn't make much of a difference in terms of time to delivery, ease of delivery, etc. Maybe the only thing is that obviously, you have less of a chance of a live baby and the ethical issues on that. But it was a well done, extensive guideline, I think, in pregnancy.
I
just to comment on
a lot about the ethical considerations specifically. From her perspective, the reason why she ultimately did not want a KCL injection was because I think she didn't want the onus of, causing the fetal death essentially. And so she just desired to just have the induction and then have the baby pass away. With comfort care measures, which is what was ultimately done. She was also a multip.
Did the baby have a heartbeat tone?
I couldn't tell from the notes, to be quite honest. I did text Maddie, but she didn't respond to me. Okay. So I'm still waiting to hear back about that. But it was, I think the induction was like less than 12 hours. Okay. Very quick. Seems like there was, not a significant amount of bleeding or anything. But, we did have I was probably speaking to her about this for about an hour before she decided what she wanted to do. Anyways, in terms of cloacal exstrophy or OEIS, it's essentially a complex that refers to a group of congenital anomalies consisting of midline defects, specifically omphalocele, exstrophy of the cloaca, and includes an imperforate anus and spinal defects. Patients can have all of these or some of these, but it is one of the most complex congenital pelvic malformations that's seen in the spectrum, which includes exstrophy epispadias complex, which includes also bladder exstrophy. The frequency is 1 in 200,000 to 400,000 live births. So again, quite rare. And in terms of data regarding male to female correlation, there actually doesn't seem to, it's pretty conflicting, the data. There is, some data that says male predominance. That's especially seen with bladder exstrophy, but again, overall the data is pretty conflicting. In terms of risk factors that are proposed, this includes IVF, maternal smoking, smoke exposure, medication radiation, and also use of clomid. So although the cause of cloacal exstrophy is not fully understood, several theories are proposed. And it seems to occur, secondarily to complications of cloacal membrane development. So typically, this is the embryology. We have like the caudal end of the hindgut terminates in the endodermally lined cloaca, which in the lower vertebrates serves as the common termination for both the digestive tract and the urogenital systems. The cloaca also includes the base of the allantosis, which we can see right here, which then expands as a common urogenital system. And so the cloaca has several membranes. It has the ectoderm and the endoderm, which acts as a barrier between the cloaca and the endodermal depression known as the protoduum. During week 6 to 7, the urogenital septum advances towards the cloacal membrane. And at the same time, you have like the lateral mesoderm ridges that extends into the cloaca. The combined ingrowth of the lateral ridges and growth then essentially move towards the cloacal membrane. And then this is what allows for division into the rectum and the urogenital sinus, which is what you're seeing in figure C. This is essentially another view, but in cloacal exstrophy, essentially what you're having is overdevelopment of the cloacal membrane. So again, this is the cloacal membrane. And this essentially prevents the mesoderm between the ectoderm and endoderm from migrating. And so the cloacal membrane doesn't actually have the mesenchymal support that we saw in the previous slide, or also on this slide too. As a result, the cloacal membrane is then unstable. And so it's more prone to rupture. And then this can lead to disruption of the lower abdominal musculature and pelvic bones. So this is just like, again, us being able to like visualize how we see these different processes and how a disruption with the cloacal membrane can then cause like a lack of fusion of different parts. So you can have lack of fusion of the urogenital sinus. The important thing to know is that the timing and the location of the cloacal membrane rupture is thought to determine the phenotype along the spectrum, because remember, it's a spectrum. Early rupture of the cloacal membrane prior to fusion of the genital tubercles and descending of the urorectal septum that divide, which is what eventually divides the GI tract from the GU tract, is what results in cloacal exstrophy. But if the rupture occurs after the septum develops, then that can lead to bladder exstrophy. So that's really the difference, and that's why it's important to actually know the embryology. There's major criteria and minor criteria for diagnosis. So non-visualization of the bladder is a very important one. You'll have a large midline infraumbilical anterior wall defect, which is what we saw, an omphalocele, and then lumbosacral anomalies. Again, you will have most of these, but not all of these. There's also minor criteria. You can have lower extremity defects, kidney abnormalities, ascites, diastasis of the pubic rami, narrow thorax, hydrocephalus, and single umbilical artery, which this patient did also. I think they had seen it in the Einstein records. So here is a picture of cloacal exstrophy here. This is more concentrating on like a sacrospinal defect. This is more of similar to what we had actually seen, but here you're really seeing the splaying of the femur. I'm going to go into more of like a classic picture that really gives you, this is a classic presentation of cloacal exstrophy. And what you're essentially seeing here includes the omphalocele varying size. What you have is this like midline plate of a cecum that's flanked by two bladder halves. That's called the bladder plate. So you have one half of the bladder, one half of the bladder. And then you have essentially this is a segment of ileum protruding outwards. And so this sign itself is called rather a elephant trunk sign. And that you can see here when the fetus is born. And this is what I really wanted to see if we actually saw that when that fetus had been born. So despite sonographic imaging and having this defined criteria, it turns out that prenatal ultrasound is a poor predictor Prenatal ultrasound reported an inaccurate diagnosis in 25% of cases. There was a series that I was looking at which revealed an accuracy of 1 in 6, which is 17% for prenatal diagnosis of cloacal exstrophy by ultrasound. Recently, MRI has been investigated to better characterize suspected cases of cloacal exstrophy. There was a retrospective review of 8 patients that found MRI to make this diagnosis in all 8 cases versus ultrasound to make the diagnosis in 3 of the 5. So if we do have suspicion, maybe we should be considering MRI imaging in these cases, which you're able to visualize again that protrusion, unable to see the bladder. Differential diagnosis includes bladder exstrophy. Here you'll see bladder going into an anterior wall defect, but you'll have a normal rectum and anus and no external bowel. Other things to consider is amniotic band syndrome, body stalk syndrome, which is more when we'll have the fetus adherent to the placenta with no identifiable abdominal cord site insertion, and then an isolated omphalocele. I also made a little chart that also kind of showcases the differences between the two. So you can compare cloacal exstrophy, bladder exstrophy, omphalocele, and gastroschisis. And then, looking at where the cord insertion is there a membrane? And cloacal exstrophy, again, you'll see it in cases with omphalocele. You will see free floating bowel, which you will not again see for bladder exstrophy. And then there will be no anal dimples. In terms of genetics, there's higher concordance rates in monozygotic twins than in dizygotic. There is a chromosome 1p36 deletion that's been associated. And then, we perform MSAFP all the time, and levels of 20 to 30 MOMs have been reported in these cases. This is actually, I think, the more interesting part is prognosis. Survival rates of 83 to 100% have been reported since the 1980s and attributed to essentially advances in neonatal intensive care surgical reconstruction techniques. But really, the overall prognosis depends on the severity of the disease. I think the more important thing to really look at is the quality of life, and that's important to counsel these patients on. This can include urinary incontinence, sexual function issues related to vaginal anomalies, uterine anomalies, gender identity issues, fecal soiling, constipation, impaired ambulatory capacity, and psychological evaluation of survivors have revealed considerable morbidity and psychosocial consequences. In terms of management, talk to these patients about termination, diagnostic genetic testing, obviously working with a multidisciplinary team. You can actually plan for induction at 39 weeks with coordinating delivery with the neonatal teams. And the most important thing to know is that the umbilical cord should be clamped and ligated at a greater distance from the infant than usual to avoid injury to the structures. Now, this is a picture if the patient decides to continue or the parents decide to continue with the pregnancy. This is what delivery will immediately. So they stabilize the newborn, they cover the exposed omphalocele, bladder, and bowel, and protect the myelomeningeal seal is the most important thing if they have a sacrospinal defect. Here we're seeing essentially coverage of the bladder and the cecal plate mucosa with an occlusive plastic wrap and silicone dressing. This essentially is just to prevent abrasions from the diaper that can, and to also keep the bladder plates moist and decrease infection. Again, we spoke about the umbilical cord. And then other things are afterwards, these patients will have very staged surgeries. So stage 1 is occurring in the newborn period where the priorities are separation of the cecal plate, rescue of the hindgut, reapproximation of the bladder halves. Later on, 6 months to 2 years of age, they'll do bladder closure, abdominal wall closure, reconstruction of the genitalia. And previously, a big issue has been gender assignment for karyotypically male patients. This patient was a male, or this fetus rather was a male. Many genetically male infants will have a very diminutive phallic structure that can't be reconstructed. So majority of the time in the past, these infants were historically surgically corrected to female and raised as female, which also brings about ethical concerns. That is all I have. Sorry.
I think, one thing to emphasize, I don't know if Huda is listening, is, the genetic part. you know, because some of these can have genetic abnormalities. Huda, you're
Yeah,
live.
so I'm sorry. Did I miss hearing what happened? She doesn't want genetics?
Oh, no, she did not, I think, no, she did not want genetics. She terminated, it's already, she delivered, vaginally last Thursday.
Yeah. And did they take pictures?
The patient declined.
Mm.
We asked.
Yeah, so there are people across the country who will be dying to get a specimen from this baby for genetic analysis, Vincenzo. So there's a lot of work that is being done to try to isolate or discover a particular gene for OEIS, basically. But this is an amazing disease. Kavisha, we did not tell you to prepare phytotherapy today. It's Eileen.
You have an early like NT or like a AFP.
I didn't see any records on that. This was done again at Einstein. She was diagnosed with all of this at a 20-week scan.
So
Yeah.
could this be identified like?
You can as early as 12 to 14 weeks, based on what I have
Absolutely.
seen,
Yeah, you
especially with
should.
a large omphalocele.
Yeah.
But really it's that distinction between the different disorders that's important.
And the importance of looking for a bladder on your first anatomy ultrasound also, right? So
like at 16 weeks probably, or even at 12.
this is something you would easily see Eileen at 11 to 12 weeks. So.
A quick search here. Karyotype anomalies 5%. Pathogenic, CNVs 11%, from CMA, and actually 22q11 is 2 to 3%. So pretty high incidence.
MFM to look up
Mm-hmm.
the different genetic disorders associated with it, and I didn't really see, like, the only one that was really associated was the chromosome 1p 6 deletion.
Okay.
Was really all they had really found an association.
Yeah, but the monogenic etiology is the thing which is currently under investigation. So, and that's the big deal, basically, to try and find the gene for it. I think I may have seen something a few months ago. I can't recall where. Nothing that I saw a particular gene for OEIS on OMEM. But basically, this is amazing. So, yeah. Do you want
Go ahead.
Yeah.
Whomever is next wants to present. Who's going?
Okay.
Whitney, you
Yeah,
wanted to present?
Yeah,
Yeah,
I have so many things.
Yeah, but one final thing. Do the fellows know? I know, Kavisha, you know what does OEIS stands for? Can you tell me what the O stands for? Sophie?
Fallacial,
Great. And the E?
extrophy.
Perfect, of the cloaca. Okay. Eileen and Sonia, what does the I stands for?
I know I breezed through it in the beginning.
Okay, I gave you the hard question. So imperforate anus, and the S stands for the spinal defects, basically. Okay. So if you remember this, it's basically the different combinations of these multiple disorders. Okay.
Okay. Jersey has been very active with anomalies. This is a good anomaly for the first years. Eileen, do you want to take a stab at what you're seeing?
Yeah, so looking at a foot and an ankle, the tibia and fibula, tibia and fibula, labeled right. Generally, I think if I can see the tibia and fibula, I should be able to see like a right angle with like a side profile of the foot, but instead I see like the surface. I don't know what it's called.
The plantar surface.
Plantar surface, there we go, of the foot. So it looks to me like a club foot.
Great. So this is a club foot. So here it is as you rightfully said, when you can see your tibia and your fibula sort of in coronal, right? You should only see the side of the ankle, and here what we're seeing instead is the plantar surface on the right. She also has a clubbed foot on the left. So here it is again. tibia, fibula, and then when it plays back, you'll see plantar surface of the left foot. So what would be your next steps, Lachey? You made a diagnosis of bilateral club feet. I'll just tell you now that there's nothing else on ultrasound beyond FGR.
Okay.
Yeah. I would talk about family history. And then I would offer her genetic counseling and diagnostic testing.
Yeah, it's actually a little, I mean, I think that's totally right. It's a bit controversial in terms of, you know, like how strongly associated isolated club foot is with genetic abnormalities, but I think certainly worthwhile to discuss and offer. In this patient with her concomitant FGR, I recommended that she have an amnio, which she declined. She has had a low risk NIPT, but the, you know, rate of karyotypic abnormalities with isolated club foot may be as low as 1%, maybe as high as 7%, somewhere in the middle there. So I think it's very reasonable. And then the other thing that we could offer her is like a pediatric orthopedic consult, just, you know, to prepare herself for, you know, potential bracing or surgery after delivery. Okay, great. So that's one. I have 4 different patients, guys.
My God, Whitney, you've been crazy busy there.
It's been crazy. This patient had something I've never seen before. So that was exciting, and I'll teach you guys a little bit about what I learned. Let me find the right pic. Sorry, this is not the right scan. This is her echo. She doesn't have a heart defect. Okay. I'm going to play this clip, and then Sonia, because I can see you on my screen, I want you to tell me what you see, okay? And I can move it slower here. What do you see? You're muted.
Sorry, I thought I was unmuted. So we're looking at the lower extremities. When I'm looking at the angle, typically you would see a right angle, which I'm not seeing here.
Yeah, so a couple of things that you're also not seeing. Do you see 2 bones in the lower leg or 1?
I see 1, and I also don't know if I'm seeing like the upper part of the lower extremity also looks a little abnormal. I'm not seeing the entire femur, but it may also just be the angle.
It's just angle. The femur is normal.
Yeah.
There is only 1 bone in the lower extremity, and it's also very bowed. So you can sort of see it here, how bowed it is. And then you're right, this ankle angle looks a little bit abnormal. I don't know, you know, from this one video, is it positional or is it persistent? So this is what the lower leg looks like. So just this 1 bone, which is the tibia. We're missing the fibula in this lower extremity. The left lower extremity is normal. And the foot, actually, I'm just going to pull up the, so this is that 1 bone in the left or the right lower extremity. That's the same bone on the left side. Obviously, the left side looks normal. The right foot, which is held at that unusual ankle, also only has 3 metatarsals. So 2, 3, so probably only has 3 toes on that right side. And then the foot was always held in that sort of like extended position. So the ankle has this sort of like extended abnormal angle to it. So this is called Let me pull it up. Fibular deficiency syndrome. It's got a couple of different names. Some people call it fibular deficiency syndrome. Other places call it anterior medial bowing. There are different types depending on how much of the fibula is present or absent. Obviously, in her case, the entire fibula on the right side is absent. Can be associated with club foot, which this baby does not seem to have, though there is an abnormal ankle. It doesn't look like it's everted or inverted in any way. In general, treatment in pregnancy, this is not a not felt to be a genetic condition. There's no known clear inheritance pattern. She declined genetic counseling, diagnostic genetic testing. The postnatal treatment for these babies is either leg lengthening procedures, multiple leg lengthening procedures, or amputation within the first year of life where they amputate at the knee. And satisfaction, parent satisfaction and patient satisfaction in the long run are actually significantly higher with amputation compared to limb lengthening because they need so many procedures for limb lengthening and they're very, very painful versus a one-time amputation in childhood in infancy that the neonate will not remember. The parents of this patient or of this baby are very, very torn as to what the right thing to do is. And obviously they're not making that decision now, but this is a really interesting case for me of something that I had not seen before.
Does she have risk factors for anomalies?
No, she's healthy. Her 3 prior pregnancies were IVF and this was spontaneous. And when we talked about this, she was like, yes, I knew something bad was going to happen to me. I don't get to just be happy.
Oh,
I know, it was very sad. This next patient is the one I showed you last week with the cystic hygroma or 2 weeks ago with the cystic hygroma. She came in for her amnio yesterday at 16 and 0. And here are all the things that we saw. So I'll just describe this to you, and then I have one more that I'll ask one of the third years to describe to me. So right transverse view of the head, there's a anechoic multiloculated mass protruding from the posterior part of the head and neck in keeping with her prior diagnosis of cystic hygroma. It is quite large.
oh my God.
In addition to this cystic hygroma, the persistence of the cystic hygroma, this baby also has a couple of other things going on at 16 weeks that I'm just trying to get to.
Does she have NIPT?
She had NIPT that was low risk. So here is it in sagittal.
What's going on?
Something is abnormal about this baby's profile. It's
What
bright,
is it?
obviously at 16 weeks, but you know, I think there might be some micronathia.
Micronathia, and is there a nasal bone?
Yeah, it could be a case of arynia. I don't see
Like the whole
nose.
face
Did you get a normal nose and lips view?
We did
Because
not. She's only 16 weeks, so we didn't. She also has high drops.
Aw.
So
Aw.
pleural effusion bilaterally.
Mm.
What we could see of the heart looked normal, though obviously limited at 16 weeks. She has, in addition to the pleural effusion, she has a small amount of ascites that you can see present here around the bowel. And then the lower extremities, because this is like an ortho day, are also abnormal.
Mm.
So just trying to find the clip of the lower extremities. They
Is she continuing?
what'd you say?
Is she terminating?
She's not she's not certain. So here's the lower extremities. They're held in this sort of like fixed overlapping position with extension of the ankles. No clear clubbing visualized yesterday, but just this like persistent overlapping position with the knees flexed and the ankles extended. So I talked to her about all this with a Russian interpreter yesterday prior to her amnio. She still wanted to proceed with the amnio, which was uncomplicated. And then we spent about 40 minutes after the amnio going over everything in detail, discussing the poor prognosis of this pregnancy, given the presence of high drops at 16 weeks. And I think she does get it. She spent a long time crying while we were talking, but she is still holding out some probably irrational hope that all this is going to go away. She's scheduled for another ultrasound that had been scheduled before the amnio got scheduled on the 10th of October. And she basically was like, I want to see what it looks like on the 10th, and then I'll make a decision. I think she will terminate. I just think she is not yet convinced that I am correct, if that makes sense. And we'll see what her amnio shows. Might have gotten these people's names. This
I
one's,
think it's the last, this is the,
And
this is the last one, if we have a minute. Go ahead.
Whitney, the other, the Hadopic patients, did you fuse an amnio?
No, I did it yesterday. I just did it.
Okay, deal. And who counseled her?
The lab court, I think Jennifer.
Okay.
Yeah, it was sent for microarray, sent for a Noonan panel, and then hopefully they'll hold cells for us as well.
Absolutely.
Yeah.
Okay, great, perfect. Jennifer is great. Thank you.
Yep. And then this is the last patient. This patient, I did not see, so don't worry. These are not all my anomalies, but Moti reached out to me about this patient, so now I'm gonna claim it as my own to show you guys. Presented for her anatomy. All right, I'll show you more, but without anything else, Sophie, what do you see?
This looks like a coronal view of the abdomen. It's labeled kidneys. There's two kind of equal sized, what look like cyst-ish looking enlargements of within each of the kidneys, although I can't really see the parenchyma very well in this.
Good.
Um,
So
and
without anything else, what would be on your differential?
it would be pylectasis, so dilation of the renal pelvis. It could be cysts in the renal parenchyma. It may be dilation of other tubular structures. It could be ureteral. Bilaterally, that would be strange, but could be. It could be unrelated to the kidney since I can't see spatially where this is. I don't know the gender of this fetus, but it could be coming from other areas of the pelvis, like the gonads. It could also be intra-abdominal bowel dilation.
Yeah, good. So it could be, as you said, just
Or
run-of-the-mill pylectasis looking strange in this sort of coronal view, dilated ureters, simple cysts in the or in the either the renal parenchyma or periphery of the kidneys. Could be totally unrelated to the kidney, like ovarian cysts, though bilaterally would be a little bit unusual. Could be mesenchymal cysts from the GI tract or GI tract dilation. Okay, great. So now I'll show you some more pictures.
Getting interesting, Whitney.
I know, right? So
Yeah.
I gotta find the last couple clips, 1 second, are really much better than the ones at the beginning.
Wow. Okay, we need to use this case for a fetal therapy.
It's a good one.
Yes.
Gotta find the last couple clips though. Sorry guys, I should really like label these images so I don't have to scroll through them in live time.
No,
But
you're good. You're good. We're good.
this is what I want. Okay. Let me find the clip of this one maybe. So what I want you to focus on here, and once it plays through, I'll scroll it slowly, is this is obviously transverse view at the level of the kidneys. And you can actually see what looks like a normal renal pelvis in part of this picture. So, or a more normal renal pelvis. I'm just waiting for it to play through and then I'll scroll it hopefully. So I think that there are actually 3 different things to talk about here. And it's
Is there a duplicated?
Okay. Sure. They
taking
look
some
normal.
time for me to play
I
it.
thought it was just fluid.
Oh,
All right, all right. It won't let me scroll in the way that I want to, which is annoying. But right here, you can see that that looks kind of normal, right? Did you guys see that? Like this part of the pelvis looks like more normal, maybe a little pylectasis, and then it gets really dilated. And then if you keep watching it play through, you know, you can see some normal kidney tissue. So, you know, when I saw this clip, I would also add to the differential like duplicated collecting system where you can have a part of the renal parenchyma, right? One of the pelvises of the kidneys looks very normal, and the other one is dilated and the ureter is dilated. So when I looked at this clip in particular, I thought, you know, consider duplicated collecting systems, dilated bilateral hydroureter, and then this thing on the left, I think is actually like another simple cyst on that left renal parenchyma versus a cyst of some other structure. But since there's a kidney issue, I feel like this is probably also a kidney issue. Does that Her amniotic fluid is normal. Her bladder looks normal. So here's the picture I was trying to tell you where I thought you could see two mostly normal renal pelvises, and then you go back and they obviously are abnormal. So I'm leaning duplicated collecting system here. One of the other things you sometimes see with the duplicated collecting system, and if we end up doing a fetal therapy about it, you know, we can talk more about this, is you can see sort of a ureterocele within the bladder where because the ureter is sort of implanted abnormally, you get this sort of anechoic like bubble within the bladder itself. We did not see that on this imaging. That doesn't mean that's not what it is, but that's my leading suspicion. So she's going to come every 4 weeks for fluid checks and continued monitoring of what we're seeing. She was also offered diagnostic genetic testing and genetic counseling and declined. I think, you know, in her case, I believe she also is FGR. So, you know, worthwhile, certainly given early onset FGR plus a renal anomaly. Sometimes isolated renal anomalies are less likely to have a genetic origin, but in her case, because she's also FGR, I thought that was important. Okay, those are all my patients. And Vince just texted me and said there's a hand thing. So that is more to, I'll show you that one when I, next week.
Wendy, there was a large cystic structure, a second large cystic structure on the left side.
Yes, correct.
Did we talk about that?
Yeah, I did mention it briefly. I think I'm wondering if it's a simple cyst on that left renal parenchyma, but you know, I'm welcome your thoughts.
There was some images when you were trying to get to that image as if there's bowel dilation in one of them. So probably I would have to review more thoroughly too, but this is a fascinating case.
Yeah, we'll see. She's going to come back. The rest of the bowel looked normal, but certainly bowel dilation remains on the differential. My thought was like, if she clearly has a kidney issue, this other thing, you know, Occam's razor would be most likely to also be a kidney issue, but you know, we can't rule anything else out entirely at this point. She's somebody who I think if it becomes less clear, we could consider doing an MRI on. I didn't feel strongly about it at
No, yeah, absolutely, yeah. Mm-hmm.
You want to start with fetal therapy?
Oh, but we sent an email to the students to tell them it's 9:40. Let me see how many.
Okay, sorry, do we have the neonatologist on that want to review the?
Our NICU babies?
Yeah, Amy's on. Thanks,
Hi,
Amy.
Amy. Good morning.
Good morning. How are
How are
you?
you?
Good,
Thank
good.
you. Yeah.
I'm just gonna go off the list that that I have on Epic. If you guys want updates on anyone else, just let me know. Um, so I'll start with our newest girl of Stephanie Medley. So as you know, she was delivered 2 days ago for maternal preeclampsia with severe features. Maybe was also severely growth restricted with reversal of end-diastolic flow. She is now our smallest baby yet. She's 310 grams. Doing okay. She is 23 and 4 days. Delivered at 23 and 4. She had a smooth resuscitation in the DR. I was there. I was actually there at her birth. She is on the high frequency oscillator in the NICU with kind of moderate settings. Is sort of just starting to end her honeymoon period now. So it looks like overnight she started getting a little bit hypotensive with wide and pulse pressures, which is likely just as a sequelae of her PDA starting to act up. So she did have to be started on some dopamine. Got her first blood transfusion overnight in the setting of um, likely iatrogenic anemia. She has had no infectious concerns, but it looks like the team sent a blood culture overnight, but we did not initially work her up for infection, as we do most of our preemies, just because she was delivered for maternal indications. She hasn't yet been screened for IVH, and obviously way too early for ROP screening. So overall, guarded, but doing possibly even better than expected at this point for a 310 grammer.
Haley, we were discussing how small in terms of birth weight was your, smallest survivor. Do you have a sense?
We had a 310 grammer many years ago, probably a decade ago, at least, who survived. I think she was a very growth restricted, maybe 25 or 26 weeker, who survived and did well. But our last couple of ones, baby Bowman, I think was 328. Baby Gordon, who's still in the NICU, I think was like 340. Baby Bowman is still a CHOP on the chronic lung disease unit, and baby Gordon is still in our NICU, although doing fairly well. So as of yet, we've had survivors.
But
Long term, yeah,
they were
they weren't
older.
20. They were
I
older, correct?
I delivered the first one. It was an IVF pregnancy. I delivered
Yeah.
that patient with Corina. We thought it was going to be 400 something and ended up being 350 or 70 grams, but it
Yeah.
was like 26, 27 weeker.
Yeah. So yeah, as of right now, I mean, we've certainly had a couple survive, but I don't think any have been 23 weeks. I can recall one 200 and some grammer we had maybe 5 or 7 years ago who survived a couple of days, but that was it. And that baby was a growth restricted 25 weeker. So I shall see. Yeah, I mean, size wise, it's not, we certainly weren't limited in any way in our resuscitative efforts. She actually had a really nice sized airway. It was just a matter, it's just very different when you're growth restricted 25, 26 weeker versus a growth restricted 23 weeker. So I think, unfortunately, her potential for her prognosis remains a lot more guarded than others. Right. Baby Carter is doing a lot better than last time I spoke to you guys. This is our 22 weeker. She is 69 days old today. She is corrected to 32 weeks. She recently completed a 4-week long course of vancomycin for MRSA, sepsis, and osteomyelitis, during which time we were really unable to treat her with steroids to manage her severe lung disease. And she was actually had to be heavily sedated and paralyzed, which we don't often do, to be able to keep her on reasonable ventilator settings and keep her fully saturated. So since completing her antibiotics, we were able to start postnatal dexamethasone on the 24th. And she was actually able to be extubated yesterday or 2 days ago. No, yesterday, sorry. And doing well so far. She is weaning on her sedation. Um, she is tolerating feed advancement. She has had no IVH, although she's starting to have some increased extraaxial fluid collection. So just concerned for not great brain growth relative to the extraaxial space. Um, her retinopathy is right now mild, stage 1. So overall, I think we're feeling a lot more optimistic than last time I spoke to you guys 2 weeks ago. Baby Close is a 105-day-old X25 weeker, 40 weeks corrected. He had a long, typical, complex 25-weeker course. He's now on 2 liters and kind of a feeder grower, just working through some reflux Brady apnea issues that are ongoing. Today, he is getting an impedance probe study just to look at the severity of reflux events to see how we can better manage him and work towards getting him home safely with oral feeds. He had a right grade 4 IVH and a left grade 1, both of which are improving. And then he did have retinopathy that needed treatment with laser on the September 3rd. Baby Dougal was 29 weeker, now 84 days old, corrected to 41 weeks. He was the baby with chylothorax, and that is long resolved. He subsequently did well, is really become a feeder grower. He's in room air now and orally feeding. However, is just having some ongoing issues with apnea Brady events, which was unfortunately just complicated and worsened a little bit by a recent rhinovirus infection that he acquired last weekend. So he's working through that, and hopefully, once that is resolved, he'll be able to go home doing well. Baby Finette Silva, 15 days old, 32 weeker. He is just a feeder grower working on oral feeds. This mom had chorioamnionitis, but he had no infection. He's done very well. Baby Gordon, this was our 350 gram, 24 weeker. She is now 112 days old, corrected to 40 weeks. She is down to 2 liters nasal cannula, doing very well, low oxygen. Unfortunately, she developed some concern for medical neck over the weekend with the bloody stool. Her x-rays look worse than she does. She was never unstable with that, just a bloody stool. So clinically, we feel it's probably more of possibly a milk protein allergy, given the lack of clinical illness. But it's a bit of a diagnosis of exclusion. So we are treating her for possible medical neck with 7 to 10 days of antibiotics and bowel rest. And again, she remains stable. She's had issues with adrenal insufficiency, has been on steroids for really all of her life. So she requires stress dose steroids for any illnesses or procedures. She had Eylea injections for her retinopathy in August, and then she also needed laser surgery last week. Baby Kierce is
About head imaging on this 24-weeker.
Oh, I'm sorry. Yes, I forgot about that. So her imaging has actually been fine. So she has had no IVH. Again, just increased extra axial fluid, which we're just seeing a lot on these preemies, and just signifies that their relative parenchymal growth is suboptimal. Baby Kier's was our 27 weeker, now 72 days old, corrected to 38 weeks. He's had a very uncomplicated course, never intubated. He's in room air, orally feeding. However, continues to have issues with significant reflux and emesis, which is precluding him from going home safely. So we're working through some of that with trying to optimize formulas and medications. He has had a left grade 2 IVH, which is improving, and then he's had no retinopathy. Baby Malera is 89 days old, 25 week and now corrected to 37 and 5. He is also doing very well on 2 liters with low oxygen requirement. He is starting to attempt some oral feeds, although not doing very much yet. He has had no IVH, and then as far as retinopathy, he is starting to progress. He's getting close to potentially needing treatment next week. So when ophthalmology saw him yesterday, they're worried that he may need laser next week. And then last but not least, baby surviving twin of Elena Tar. This is the female twin. She's 58 days old, 25 and 2 weeker. She's corrected at 33 and 4. She's done extremely well. I think her current level of support does not reflect how well she could be doing. Unfortunately, her parents have been extremely hesitant to allow us to wean anything. They are just understandably very nervous that she will decompensate with any wean that we make. So she's still on non-invasive nasal ventilation, but really could be on much lower than that. We've sort of been trying to meet them halfway and making reasonable weans, but not pushing her too much. She is still on full tube feeds due to her level of respiratory support. She has had no IVH. And then her retinopathy is also progressing, and also is a possibility for needing laser in the next week or two. That's all the babies that I had on my list. Is there anybody else that you guys wanted updated about right now?
Oh, I think
The one that I don't see on the on my list is baby Sizer, who is also a small baby. I'm just looking through the census list now. Let me just pull up his note here. He was I believe 27 weeker. Yes, 27 weeker. He's now 32 weeks corrected. He was intubated for some time, but is now on CPAP. He is gavage feeding. He just has a small grade 1 IVH, and then he is just 4 weeks old, so hasn't yet been screened for retinopathy.
Thanks, Amy. I think that's all we want a great review. Thank you.
Sure. Thanks, guys.
yeah, this is great. Welcome everyone. Welcome our genetic counseling students. Today we're going to have our first year fellow, Eileen Wang. She's going to teach us about very important topics related to the fetal kidneys, specifically autosomal recessive polycystic kidney, autosomal dominant polycystic kidney. And it's so important to do these fetal therapies because this is how we really stay up to date. She's going to discuss with us some new publications, guidelines that have been addressed internationally on this topic. With that said, Dr. Wang, thank you so much for your preparation for today.
Thank you, Dr. Alquatli. So let me just share my screen here. Perfect. All right. So as Dr. Alquatli said, my name is Eileen, first year fellow, and today's presentation will be on maternal and fetal diagnosis and management of renal cystic disease. So I'll begin with a case presentation, and then I'll go into the 2 most common forms of genetic renal cystic disease, autosomal dominant polycystic kidney disease, or ADPKD, as well as autosomal recessive polycystic kidney disease, or ARPKD, and how they affect both mother and baby. And then I'll walk through the differential diagnosis if renal cysts are detected on fetal ultrasound, and highlight some other important factors to consider. So we'll start off with a case. This patient is a 34-year-old G3P1011 who presented at 14 weeks and 2 days for her initial prenatal visit. She was pretty medically and surgically uncomplicated, history of GNAMA1, asthma, had a prior cesarean delivery, and a laparoscopic mastectomy. On the left, I'll go over the maternal course. Around 15 weeks, she gets routine labs drawn that were ordered by her PCP a few months prior, including a CMP that was noted for an AST-ALT elevation of 205 and 376. And because of that, a week later, she gets a right upper quadrant ultrasound performed, which shows normal liver and bile ducts, but on the ultrasound, they noted a right kidney with increased echogenicity and multiple simple cysts, the largest of which was 2.2 centimeters. And then in addition to that, she gets bile acids drawn for her transaminitis, and they were elevated at 12.3, and her transaminitis resolved. So the working differential for that is ICP. And you can see that ultrasound here on the right of her kidney cysts. At the same time, this is the fetal course, the fetal/genetics course. At 14 weeks, she gets an NT scan done of her baby that was with the normal limits. She has an NIPT that was drawn in low risk. Although, at the same time that she's getting all her new OB labs drawn, her AFP comes back, MSA-AFP comes back elevated at 3.04 multiples of the median, and the cutoff was 2.8. So as a result of that, she gets an early anatomy at 16 weeks, and the fetus is noted to have a right pyelectasis, as well as a right choroid plexus cyst. As a result of the fetal finding, she undergoes genetic counseling, and the genetic counselor goes over the right upper quadrant ultrasound results as well, and she is noted to have a strong family history of ADPKD. In her mother, 3 maternal aunts, and 1 maternal uncle. And so, she ends up getting an amniocentesis for the fetal findings. They draw an AFP that was within expected limits, and then the microarray comes back as a normal male. At the same time, the mom is referred to nephrology, who they order maternal PKD testing, and that is positive for a pathogenic non-truncating variant of ADPKD. And so that you can see that result here. Sorry, it's kind of small, but the PKD1 gene is affected, and it's thought to be a missense mutation. And then, on follow-up fetal ultrasounds, the pyelectasis is noted to be resolved. The kidneys are otherwise normal appearing. She was counseled about her the mom was counseled about her own genetic diagnosis, and, was offered genetic sampling for the fetus, but there was not enough amnio sample from that original draw to send for ADPKD testing. So this case really prompted me to explore ADPKD in pregnancy, and kind of because they're both interesting from a maternal and fetal perspective. So it's a late onset multi-system disorder, most commonly characterized by bilateral kidney cysts, liver cysts, and an increased risk of intracranial aneurysms. And the patients can also have dilation of the aortic root and dissection of the thoracic aorta. The kidney cysts are the most common manifestation, and as a result of them, they can develop early onset hypertension, kidney pain, as well as renal insufficiency. And ADPKD is a progressive disease that is age and genotype dependent. So clinical onset doesn't really start until around age 30 or 50, age 30s to 50s. And about 50% of patients will develop ESRD by the age of 60. And the incidence is thought to be about 1 in 1,000 births. It is a genetic disorder that is most commonly caused by a mutation in the PKD1 or PKD2 gene. The PKD1 gene is is more commonly associated with the disease, although it has also been associated with these other genes, as you can see here. And the PKD1 and the PKD2 gene encode for the polycystin protein, which I'll get into in a little bit. But as the name suggests, it is inherited in an autosomal dominant manner with a 50% chance of passing on to offspring. And around 10 to 20% of affected patients are thought to have it as a result of a de novo pathogenic variant. Those who have the PKD1 mutation often experience more severe disease at an earlier age compared to those with PKD2. So kind of an onset of around 58 years of age versus 75 years of age for PKD1 versus PKD2. And then the diagnosis is usually by kidney imaging criteria and an infected first-degree relative confirmed with ADPKD. So that would have been the case in our patient. Or you can obviously directly test the patient by identifying the pathogenic variant on genetic testing. And then I just wanted to go over the imaging criteria for future reference, but it is age dependent. So generally you can get either an ultrasound or an MRI of the kidneys for ages between ages 15 to 39. You should see about 3 or more kidney cysts, either on one or both kidneys. And then between ages 40 to 52, you should see greater than 2 cysts in each kidney. And then for an infant child who is at risk of developing ADPKD, like for example, their parent has it, you can diagnose it based on large echogenic kidneys without distinct macroscopic cysts. And in order for to test for it, you can either use a multi-gene panel, such as using the genes listed here, versus performing comprehensive genomic testing and truncating variants, which result in a complete loss of function of the polycystin protein, often lead to more severe disease than the non-truncating variants. So form with an onset of ESRD around 55 years of age, and the latter with the onset of 68. So in our case, it was a non-truncating variant. And then, as I mentioned before, it is passed in an autosomal dominant manner, where an affected parent can pass on the allele to the child. You know, if both parents, let's say, had ADPKD and passed on their respective alleles onto their child, this is generally considered incompatible with live birth. And then there are also rare situations in which both parents have a hypomorphic or non-truncating variant, meaning they only have partial loss of gene activity. And if they both pass that variant on, they can lead to a neonatal onset ADPKD, and that's often mistaken for ARPKD. And so this can also occur through uniparental disomy, where the child inherits both copies of the pathogenic variant from one affected parent. And then in terms of the pathophysiology, the genes PKD1 and PKD2 produce the protein polycystin 1 and 2. And the polycystin usually localized to the primary cilium of renal tubular cells. Therefore, so when these mutations cause a loss of function, this impairs ciliary signaling pathways that regulate cell proliferation, polarity, and fluid secretion. And so this ultimately leads to the formation of cysts. It's not small on the screen. And then the cysts eventually expand, which cause parenchymal compression, inflammation, and fibrosis, and eventually apoptosis, which is why kidney function declines. In general, for adults diagnosed with disease, the primary goal is to slow progression to kidney failure and treat its complications. So key interventions include strict blood pressure control below over 75, usually with ACE inhibitors or ARBs, lifestyle management with weight management and sodium restriction, and then just managing kidney stones as well as flank pain. Patients should be screened with a head MRI for intracranial aneurysms if there is a family history, and then also with a echo or heart echo if there's any murmurs heard on cardiac examination, or if there's a family history of dissection or aneurysm. And the only disease-modifying therapy is tolvaptan, which is a vasopressin V2 receptor antagonist. That's the only one that has been shown to slow down progression to ESRD, but this is contraindicated in pregnancy, and people often discontinue it if they're trying to get pregnant. And then finally, once ESRD develops, the patients require dialysis or transplantation. So how about management during pregnancy? And so there's only a couple of studies that looked at pregnancy outcomes in patients with ADPKD. And this is the most recent one I could find by Wu et al., who performed a case control study of 146 women with renal cystic disease during pregnancy. 54 had ADPKD and 92 had simple renal cysts, and those were the controls. And essentially, they found that ADPKD patients experienced significantly higher rates of maternal complications, so 34.8% versus 6.5% in controls. And they specifically had increased rates of gestational hypertension, preeclampsia, and worsening chronic hypertension. And they also found increased rates of elevated serum creatinine. For example, only one ADPKD patient had abnormal creatinine prior to pregnancy, but 12% developed it during pregnancy versus none in the controls. And then finally, they had increased rates of UTI and proteinuria. When comparing fetal outcomes, they were largely similar between groups. Live birth rates were comparable, 80% versus 76%. Preterm delivery showed a trend towards higher rates in the ADPKD group, 11 versus 6%, but this was not statistically significant. Fetal distress was significantly higher, but I'm not really sure how they define that in the paper, because otherwise the neonatal outcomes and C-section rates were similar. And then there were increased rates of induction of labor for ADPKD patients, but they didn't really say the indication for induction, but it makes sense if they are also higher risk of developing gestational hypertension. Yeah. And then they followed these patients over an average of 20 years. And of course, consistent with ADPKD progression, those with the disease had higher risks of renal insufficiency, proteinuria, and chronic hypertension. But they concluded that this was most likely related to the natural progression of the disease rather than related to the pregnancy or multiparity itself. And they did like a separate analysis whose data, like the data was not included in the paper, but they found that there was no difference in complication rates among those with higher number of pregnancies compared to fewer. Kidney Disease Improving Global Outcomes, or KDIGO, is an international organization that develops evidence-based guidelines for kidney disease, and recently published one for ADPKD management in February 2025 that included a dedicated section on pregnancy. And so in addition to the aneurysm and cardiac screening we had previously discussed, they recommended discontinuing tolvaptan, ACE inhibitors, and ARBs prior to pregnancy and during lactation. They suggested, or they recommended, monitoring blood pressures, preferably at least weekly with a home BP cuff, and regular assessments of CMP and proteinuria. They recommended a goal of less than 135 over 85. And then and that also mentioned, given the increased risk of UTI, they recommend monthly urinalyses for asymptomatic bacteria. Interestingly, they also kind of suggested measuring the sFlt1 PLGF ratio every 4 to 6 weeks after 24 weeks to predict preeclampsia risk. And for those who are unfamiliar with the test, this ratio is used for preeclampsia risk stratification. So a low ratio can rule out preeclampsia development within 1 week, while an elevated ratio indicates an increased risk and a shorter latency to delivery. This approach, though, is not yet standard practice compared to traditional risk models. So I don't think I don't know if we do that here, but let's just discuss. Okay. And then, of course, patients should be started on low dose aspirin for preeclampsia prophylaxis. And then genetic counseling should be offered, though decisions regarding genetic testing should involve shared decision making, given that ADPKD is typically an adult onset disease. And then, since this disease usually develops later, one of the questions I had was, is it possible to detect this prenatally? And they have been reported in the literature. This study by Bruin et al. Looked at 27 fetuses with confirmed ADPKD, and they found that the most common presentation was moderately enlarged kidneys, a hyperechogenic cortex, as you can see here, and hypoechogenic medulla. That was the most common presentation. And then only 4 out of the 27 fetuses showed visible cysts prenatally, and the majority of which were after 30 weeks. The A5 was normal in around 89% of the cases, and most infants had good perinatal outcomes. Interestingly, that study only 5 fetuses had a known family history at the time of ultrasound examination. So in the remaining 16 cases, the parental ADPKD was discovered after suspicious fetal ultrasound findings. And so they got renal ultrasounds and were found to have cysts. So it was pretty interesting. But regardless, overall prenatal ADPKD diagnosis is rare. Only 1 to 5% of affected persons present as newborns. So if the parent has it, they should be counseled that a normal fetal ultrasound doesn't exclude it in their child.
And then a homozygous AD will look or resemble like the autosomal recessive format.
Let's go back. That's a great question. Go back to that slide, Eileen, that the slide.
Yeah.
No, not you're going too fast. Just a slide that talked about the prenatal presentation for ADPKD, because that's a very important distinguishing factor. So you as MFM providers in the ultrasound unit, how am I gonna think about it? So the typically, in both disorders, the kidneys are going to be enlarged. In autosomal recessive polycystic kidney disease, they're going to be homogeneous. The cysts are not going to be large like this one. The cysts are microscopic, so you cannot see them. So you're going to see big white kidneys. That's one distinguishing factor compared to this. Second, the fluid in ARPKD is going to be oligo or even anhydamnias. Here, because we know these kidneys continue to function, right? Because many of these diseases have adult onset presentation, you can see normal fluid. So, and that's why, Eileen, we discussed, the fetal presentation for these disorders is very important for us as maternal fetal medicine specialists to be aware of. So thank you for working on that. Great. Kavisha, did I answer your question?
Yeah, I just in terms of the homozygous, presentation would it be similar to then a ARPKD in the fetus? If we're looking at it,
No, it shouldn't, because remember you're gonna have cystic kidneys and the kidneys are gonna be functioning, right? So it's gonna still have the same.
Not compatible with.
Yeah, no, I think what she meant was for if both parents were affected with ADPKD and the fetus was homozygous, so it had both 2 copies of the.
Oh, 2 copies of the ADPKD,
Right.
you're saying.
Right.
I know it's super rare. From this report, it sounds like it's incompatible with life. I don't know if the fetal findings on ultrasound are the same, or what they found on those specific.
Or if it just doesn't.
Yeah. We can probably look and see for case reports. So I do not know the answer to that question, Kavisha. I thought you were asking about the fetal presentation for ADPKD versus the autosomal recessive form, the ARPKD.
No, I know I leave it.
Which is the common thing you're going to be seeing in ultrasounds.
Yes.
Thank you. I'm glad. Great.
Thanks for the transition.
Real quick, The 92 patients in the study, right?
Yeah.
Were they diagnosed genetically or by ultrasounds or both, or do you know? I was just wondering,
No, for the
the 92, the beginning, when you like pregnancy complications, for mom, you had
This
some
one.
cases. Yeah, this
yes,
one.
this one for the mothers, they had already been diagnosed genetically.
So mostly probably the one mutation,
Mhm.
number one. Okay. Just, thank you.
All right, so now I wanted to move on to autosomal recessive polycystic kidney disease, or ARPKD. So this is a cystic renal and hepatic disease that is significantly rarer and more lethal than ADPKD. The incidence is about 1 in 20 to 30,000 births compared to 1 in 1,000 for ADPKD. And approximately 20 to 30% of affected infants die in the first year of life. And it is a major cause of ESRD in children. There are two subsets of the disease, and it's classified by the timing of initial presentation. There's perinatal, which is prenatal to 4 weeks of age, and then infantile, which is 4 weeks to 1 year of age. And the key distinguishing feature between the two is pulmonary involvement in the perinatal presentation, which is the primary cause of neonatal death in those affected. And so since we as MFMs may encounter this condition prenatally, I'll focus more on the perinatal form. ARPKD is usually caused by a gene mutation in the PKHD1 gene, which affects the fibrocystin polyductin protein in the primary cilia. And unlike ADPKD, where it occurs throughout the nephron, this one usually just affects the collecting ducts in the distal tubules of the nephron, which is in the medulla of the kidney. And again, ARPKD follows an autosomal recessive inheritance, so both parents must be carriers, resulting in a 25% risk of an affected child with each pregnancy. And there are certain scenarios in which you might suspect ARPKD on ultrasound, which I'll get to in a little bit, in which case you can offer amnio and either perform a multi-gene panel testing or exome genome sequencing. And the reason why you want to test a number of genes rather than just PKHD1 is because there's several other cilia-related disease genes that may mimic ARPKD, for example, PKD1. And so other mimickers can be caused by mutations in the HNF1B gene or the hepatocyte nuclear factor 1 beta, and that can lead to hepatorenal fibrocystic diseases, or genes that cause the Bardet-Biedl syndrome, which is another rare ciliopathy that can cause retinal dystrophy, obesity, post-axial polydactyly, and cognitive impairment. And then in particular, biallelic truncating variants, as compared to missense variants or compound heterozygotes for truncating and missense variants, leads to complete loss of protein function and therefore often have the most severe phenotypes. And so genetic testing is important in these cases to give a sense of perinatal outcomes. And this kind of goes back to the perinatal presentation on ultrasound. So if you detect them, what you might see are bilaterally enlarged, homogeneously hyperechogenic kidneys with reduced corticomedullary differentiation. So you can kind of see here, this is a coronal view of the fetus, and it basically has the same like echo texture throughout. There are certain scenarios where you might also see microcysts, which are, I mean, these are tiny on this ultrasound, but they might have a salt and pepper appearance as seen here. And the macrocysts are uncommon, but they are possible. And again, you can also develop oligo or anhydramnios. And these findings can be detected around the time of anatomy ultrasound between the 21st and 24th week. Ultrasound is the first line tool for the prenatal detection of renal cystic disease, but you can use fetal MRI in selected cases, particularly when ultrasound findings are equivocal, when there's severe oligohydramnios, or when there's other suspicion for extrarenal involvement. And so here's an example of an MRI where you can kind of see the kidneys, the fetal kidneys representing in the cysts here. I don't know. And then if you identify these findings on ultrasound, other than offering genetic testing, the most important thing to do is monitor for oligo and anhydramnios, as this can lead to pulmonary hypoplasia and Potter sequence, as you can see here on the right, which because of like the decreased amount of fluid and kind of compression of the fetus, this can lead to flattened face, low set ears, and limb difficulties. And then the enlarged kidneys, as you can see in row B, can limit the diaphragmatic excursion and lead to respiratory distress in the newborn. And persistent pulmonary hypertension may also be present. And these kids also might have feeding difficulties secondary to mechanical compression of the stomach. In terms of neonatal outcomes, the largest study is by Bergmeyer et al., who analyzed 385 patients with ARPKD from a registry spanning 18 countries. And the study aimed to identify risk factors for early dialysis dependency. And if you look at their table 1, they found that the mean gestational age at birth was approximately 37 weeks. 34% had oligo and anhydramnios identified, and 26% had increased echogenicity. Of note, so here's the column with all cases, and here's the column with children requiring dialysis in the first year of life. You can see that of those requiring dialysis in the first year of life, they had a higher percentage of oligo and anhydramnios on ultrasound, as well as enlarged kidneys and renal cysts. So we are mostly kind of seeing patients in this category here. Overall, 23% needed assisted breathing or ventilation, 25% needed admission to the NICU, and this was even higher for those with more severe phenotypes. This is a registry of all cases and phenotypes of ARPKD, so likely as we as MFMs are going to see the more severe ones that develop prenatally. And then the predicted probabilities for early dialysis varied from around 1.5% for patients with no prenatal sonographic abnormalities to 32% in the cases of documented oligo, renal cysts, and enlarged kidneys. In terms of delivery planning, these babies really should, get frequent ultrasounds prenatally, at least every 2 to 3 weeks for assessment of renal size and AFI. They should be delivered at a center with NICU and pediatric nephrology. And interestingly, early delivery and cesarean delivery are not necessarily recommended as they don't improve outcomes. But one thing to keep in mind if you're attempting a vaginal delivery is that there have been case reports of abdominal dystocia in these patients, given the large kidneys. Data on serial amnio infusions are really insufficient at this point for oligohydramnios, and then you can consider prenatal steroids for late preterm fetuses for lung maturation. And here's a summary table of the differences between ADPKD and ARPKD, which we already went through, but just for your reference in the future. And just to emphasize, we will probably see maternal ADPKD more often, and so kind of just from a maternal perspective, like that's kind of what we might be focusing on, whereas really ARPKD will focus more on the fetal manifestations. All right, so now I wanted to pivot a little bit to discussing what should be on the differential if we see an abnormal feature of fetal kidneys on ultrasound, because that's how we're often approaching this as MFMs. And so this was actually a really nice paper by Gimple et al. That was published in JAMA Pediatrics on the perinatal diagnosis, management, and follow-up of renal cystic or cystic renal diseases. And specifically, I'll go through their table 2, which kind of looks at the likely diagnoses and differentials for solitary renal cyst, multiple unilateral cysts, bilateral cysts, or hyperechogenicity without oligohydramnios, and then with oligohydramnios. So if you find a solitary renal cyst on ultrasound, as you can see here on the picture on the right, the most likely diagnosis is a single cortical cyst. And although the other possibilities include a dysplastic upper pole of the duplex kidney, which we talked about with Dr. Bender's patient, extrarenal cyst, or the beginning of a polycystic kidney disease. Generally, you would want to get a follow-up ultrasound in 4 to 6 weeks to exclude newly developed cysts. And then if the cyst is stable and there's no others, then this does not require regular follow-up in pregnancy. You should consider genetic testing only if there are extrarenal manifestations, and just because the genetic pathology is pretty rare in circumstances. And then fetal MRI is not needed in this case. Natally, pediatrician should be informed, and the baby should get a renal ultrasound within 4 weeks after birth. If you see multiple unilateral cysts on a kidney, the most likely diagnosis is multicystic dysplastic kidneys, or MCDK, which is a result of disrupted interactions between the ureteric bud and the metanephric mesenchyme during fetal development. And so generally when you see this, you want to do a comprehensive anatomy because it could be part of the Bacterial syndrome. You also want to assess the contralateral kidney to see if it has compensatory hypertrophy and normal parenchyma, so that means that carries a good prognosis. And genetic pathology is usually rare for unilateral cystic dysplasia. So again, consider testing only if there's extrarenal manifestations. Again, you can get a follow-up ultrasound in 4 weeks. Fetal MRI is typically not needed. And then postnatally, the kids will get a renal ultrasound between days 3 and 7 of life. And here are some other images of what MCDK looks like. As you can see here, they're usually variably sized cysts that don't connect with little renal tissue. So I think a much different picture, I think, than what I'll go into next. So if you identify bilateral cysts or hyperechogenicity on ultrasound, the most likely diagnosis, I know we've talked about ARPKD and ADPKD, but most likely diagnosis is actually bilateral cystic dysplasia with or without obstruction. And again, that's not purely genetic, but genetic condition should remain under differential diagnosis. The other kind of, I already mentioned the HNF1B mutation, the Bardet-Biedl syndrome. Meckel-Gruber is also a ciliopathy that is also characterized by occipital encephalocele, as well as postaxial polydactyly. So that's kind of the triad. Multicystic kidneys, and then those two. Other things to consider on your differential are drug toxicity. So they specifically mentioned ACEs and ARBs, and then lower urinary tract obstruction. And then, of course, as part of your routine anatomy, just do a complete organs screening with a special focus on CNS and the heart, offer genetic testing and counseling by pediatric nephrology, and then do serial ultrasounds every 4 weeks. You can consider a fetal MRI in selected cases, especially if it'll give you more information about CNS malformations. And then postnatally, these infants should receive a renal ultrasound within the first week of life, and then any additionally imaging based on other organ findings. If oligohydramnios develops, ARPKD and other genetic syndromes become higher on your differential. And then pretty much you would make the same recommendations as the previous slide, but the article argues that an MRI should be recommended because there's a significant advantage for imaging fetal kidneys in the CNS, especially when there's oligo or anhydramnios. And I think in that paper, they did like a systematic review, which showed that like an MRI could change the diagnosis then as compared to ultrasound. And, as I mentioned before, fetuses with oligohydramnios overall have a poorer survival because of the neonatal respiratory disease and longer-term renal dysfunction. But it also depends on, what the underlying genetic diagnosis is and other organ involvement. As I mentioned before, there's insufficient evidence for serial amnion infusions. You can consider corticosteroids. There's not much evidence on that, but they suggest that it's like, potentially beneficial. And then postnatally, they'll need a renal ultrasound as soon as possible. Any additional imaging. That's basically it.
That was an amazing presentation, Eileen. Thank you so much. This is great. And, I hope, for the fellows, I'm sure you learned a lot and the genetic counseling students. So basically, we started with a patient who was just seeing us for like a genetic consult, unrelated. And then we found out the issue with the kidneys, sent her to nephrology, and here you go. Her life is completely changed now. She knows she have ADPKD. She's going to know that she's going to have a high chance of ending up with end-stage renal disease that may require dialysis. And then it's going to have health implications for all of her children also, with a 50% chance. And then think about the siblings too, right? So this is a this is a huge diagnosis. I was in scans Monday, and I think I had the same case. I was just seeing someone for a fetal weight, and then I stumbled into anal ultrasound that had multiple cysts bilateral. I already immediately sent a message to Eileen, and she's like, "Oh my God, another ADPKD patient." So our MFM nurses worked promptly, and she's seeing nephrology today. Thank you, Melissa, for your message. So with genetics, you really can change, the life for these patients. It was music to my ear to hear you talking about truncating variants, uniparental disomy, ciliopathy. All of these are new terms to Eileen, but just to give you a taste of how much you learn, with this fetal therapy. And I also learned, I didn't know these patients are gonna need monthly urine analysis. As an MFM, I didn't. So now we're going to be updating her chart and putting that there, that this patient is going to need the monthly urine analysis, basically. And going forward, this is something that we also learned a lot. So what questions you guys have? Fascinating presentation. Thank you, Dr. Wang.
I thought it was just so interesting. I mean, this is like the perfect representation of maternal fetal medicine, just like
exactly. Yes.
You can see from like the course, I was trying to like do it in parallel because like, as we're working up the fetus, like we're also working up the mom, and like unfortunately, and just through the genetic counseling for the fetus, we found out about like the family history. Like we don't really ask about family history that in depth. Like I don't know. I probably should do a better job of that in my.
And a 25, 30-year-old mom may never have had her kidneys imaged, may still be asymptomatic, and there's a way to diagnose it.
Yeah. And you see how it affects preeclampsia, serum creatinine values. You presented all of this data. So you kept us also up to date with that international guideline. So that's fantastic.
Yeah.
Anyone have any questions for Dr. Wang or myself today, or? I think it's interesting how Eileen also presented the table of the different genes. So it's not only one gene, right? There are other genes that are rare, but we have to think about the entire spectrum of the genetic disorders. Yeah. So that's great. Thank you so much, Dr. Wong.
Thank you.
And genetic counseling students, I hope you learned a lot today.
Thanks, everyone. Thanks, Aileen. It was great. And this is stuff that you'll see frequently.
Absolutely.
It's
Yeah.
renal disease. In fact, there's some studies that talk about the disease that may affect neonates and infants that we either undiagnose or don't diagnose prenatally. It's renal disease. Like renal disease is common enough, and sometimes we don't place enough emphasis on it. So I guess the next thing it's outpatient list is that.
I got it.
No, you're up to. Anything else before that? So cold.
It's freezing.
I have to. Winnie, if you're not interested in the outpatient list, you don't have to listen in, just to let you know.
No, I'm very interested.
Okay, well, you can stay there.
All right, I'm gonna keep it minimal for patients that don't have a lot of updates since we talked last 2 weeks ago. But this is Armani Bennett. She's a 23-year-old G4 P003. She's 32 weeks and 6 days today. She's on our list for thickened fold, for which she declined amniocentesis and early onset ICP. For the early onset ICP, the most recent update is that we saw her yesterday. She'd stopped taking her ursodiol. Sadly, I told her to, and so her symptoms got worse. I told her to please take her ursodiol. She did complete the GI labs that were previously recommended. Her celiac screen was negative. The ceruloplasmin was elevated, but mildly, and GI did not seem impressed. And then they sent an EBV.
Ceruloplasmin can increase in pregnancy. It's one of those proteins that can increase. You know what it's related to?
Yeah, the
Rare.
Wilson's,
Yeah, Wilson disease. Yeah. We've had a couple cases in 30 years of Wilson. I don't see too many. And it's naturally elevated, I think, in pregnancy.
Well, that was good to know. I did not know that. EBV quant was negative. I'm not sure how long that would stay positive in an infection. If we were thinking, remember this patient had positive EBV, IgG and IgM when she was first worked up. So she last had bile acids 2 months ago, and we ordered them for repeat yesterday along with LFTs. They're not back yet. Her last bile acids were, as I said, in August, and they were 28, down from 103 in July. We previously discussed delivery timing for her being after 36 weeks. Dr. Roman and I kind of settled on 37 weeks for her just to avoid a preterm delivery, but given that her bile acids were over 100 at the time of diagnosis, we're hesitant to push beyond then. She's all scheduled for her NST, and she had her last growth ultrasound yesterday. That was normal. Anyone disagree? The next patient is Denise Brown. We saw a lot of people yesterday, majority of these folks. So Denise Brown is a 34-year-old G4 P0120. She's 13 weeks and 4 days today. She's on this list for type 2 diabetes. She has Cushing syndrome, chronic hypertension, elevated BMI of 46, and a history of like a 20-week IUFD. For her type 2 diabetes, she was fine yesterday. I think she was 70% in range. She's on 2JO. And then we upped her list for a little bit to 22, 34, 34. She's wearing her Libre. We redid, it wasn't yesterday, I think it was 2 days ago. She has a history of an abnormal pap smear. We redid her pap smear. Her Cushing's disease is stable. She's on 5 milligrams of prednisone daily. She has chronic hypertension and she was normotensive and well controlled on 30. She has an abnormal echo that she's seen Dr. Jones for in cardio OB. She has a repeat BNP that's pending from a few days ago, and we're planning to repeat a third trimester echo. She had a normal ejection fraction, but this like dynamic obstruction with Valsalva. So the plan remote from now, but at the time of delivery, is to avoid diuretics and avoid hypovolemia to not worsen the dynamic obstruction. Anyone have questions about her?
Sorry, I missed the presentation. We're still talking about Brown.
Yep.
I've been watching her diabetes control and she's much better at 70%. I'm watching and messaging her every other day.
Yeah, I saw that. Thank you. We saw her recently too. She's improving. Allison, I think everyone knows, 26-year-old. She's 24 and 1 today, the monodi twins with the twin B demised at 16 weeks. We also saw her recently in clinic. The biggest update for her is that her fetal MRI is now scheduled at Nemours for next Wednesday, the 8th, for the surviving twin. I don't have any other little updates for her. Any other questions?
Hi, so it's Alexa. The MRI is at CHOP.
Oh, sorry, CHOP, not Nemours. Thank you, Alexa.
Sure, no problem.
Anything else for her?
No, I actually didn't see her. I just said hi to her in the waiting room. I didn't get to see her after that, but that was the biggest update. Just took a while because she needed a double slot, and it's hard for them to find that initially.
Well, thank you for helping us with scheduling of that MRI. I appreciate it.
Sure, anytime.
Caitlin Cleaver, she's a 35-year-old UNP0 at 24 and 3. She's on this list for vasoprevia. It was diagnosed on the 26th at a 23 and 5-day ultrasound, type 2 anterior placenta with a posterior accessory lobe. She's scheduled for a consult with us on the 8th and her next growth ultrasound at the end of the month. Otherwise uncomplicated.
So are we offering lasers to everybody with this?
Type 2, right?
I mean, I think we should be discussing them if they have a type 2 vasoprevia. I don't know that it's going to be right for everyone. Not everyone's going to be able to travel. Not everyone's going to want a fetoscopic procedure, but I think the way I plan to approach it is to like mention historically we did this, we're now doing this. Are you interested in hearing more about it or learning more about it if they're a type 2?
And we're sending them to Hopkins, I guess that's the closest place.
Yeah, I think so. Hopkins and Columbia is doing it as well, though. Hopkins is where our rheumatologist went.
Right.
Okay, we can mention it at her consult with us on the 8th. The next patient is Jessica Green. She's a 34-year-old. She's a G3P0020. She's at 31 and 6. She's on this list for proteinuria. We discussed her too. That's now newly diagnosed Alport syndrome. She has a plan of care established with nephrology. There's no real updates to that. She is going to be started on an ACE inhibitor and SGLT2 postpartum, so she's not going to breastfeed. She has her next appointment on the 17th with Carrie, and then she's a follow-up with Stephanie on the 3rd. She has no other real relevant.
How much proteinuria does she have?
Like almost 4 grams.
Okay.
Nephrotic range, so 6,218.
That's a new one.
So then just a FYI again on the teaching side, when you have proteinuria over 5 grams, there's an increased risk of VTE. And there's always the question, do you put these patients on prophylactic, pharmacologic therapy or not? Whitney, you're shaking your head.
That's because I had the same teaching point when I saw her in clinic last time, and I reached out to the nephrologist to say, why is she not on anticoagulation? And he said that that increased rate of VTE is most commonly seen when somebody has a certain type of nephrotic syndrome, which Alport's is not. And so he felt like in the absence of other risk factors, even though pregnancy is its own risk factor, that she did not need anticoagulation, but we did talk about it.
Thank you. We also saw the next patient this week. Today, this is 37-year-old. She's a G8P. Any numbers? 1516. She's 28 weeks and 4 days, or sorry, 5 days today.
Exactly.
She's the patient with a monodi pregnancy. What's the Lotus birth of both twins, preferably, but at least twin B. She also has asthma that's being managed on Symbicort and Inhaler. She showed a home appointment, and I think per our new like office policies, we're not continuously rescheduling with outside departments. She also has pretty significant iron deficiency anemia. Her hemoglobin was 8.9 on the 14th of this month. She no-showed her heme appointment on the 25th, and therefore they canceled her infusion that was coming up for next week. Melissa was working on rescheduling her yesterday. We suspect that she's been reporting these like loss of consciousness or like sleepy kind of episodes, and we suspect it may be due to very severe anemia. And would like that corrected before we continue to work those up more. She's going to continue with twin transfusion screenings every 2 weeks. She had a growth ultrasound yesterday. I don't think the read was in yet last time I checked. And then we told her regarding the Lotus birth that she would consult with ICN when she came in to deliver to discuss further. Dr. Roman and I discussed that yesterday. Any questions?
Shall we, if we can't teach her for outpatient team consult, this is someone I would consider admission for like a day or two and give her some IV iron.
Yeah. So
it's 28 weeks. She probably needs Epogen too.
She reports that she was just running late for the appointment and then they canceled it on her. So we were going to reschedule at least the heme one more time. But I agree.
She's almost 29 weeks. I would call her today, bring her in for a day or two of IV iron and finish.
We could bring her to the triage setting. I don't know if that she'll stay because of her 6 kids at home. Like she usually, she probably will not stay. She's more likely to attend an appointment, I think, than be admitted to the hospital.
I sent him a message yesterday. I'm just waiting to hear back. They're usually very responsive.
Yeah.
So I'm hoping to hear back today.
Specific times where she needs an appointment because of her kids' schedules. So, but we could do it in triage. Potentially,
I think, Sophie, this deserves a phone call to tell her the complications of her hemoglobin being 8 with the twin gestation.
I surely counseled her on those top to bottom today.
Okay.
Risk of hemorrhage being number 1 and not having enough reserve, and risk of, blood transfusion, needing critical care.
Yeah. Like this is a patient, like even just with the usual blood loss, let's say, hopefully it's only 1 liter, she's going to go to hemoglobin of 5. So you can imagine if she loses 2 liters, her hemoglobin is going to be 2.
Can I ask how, the heme department feels about us just ordering IV iron and going directly without the heme appointment? I'm just curious.
They just do a telehealth typically and order some lab. They just want to make sure, as long as we order labs, they're pretty good at getting the patients into the infusions. Really, it's just to make sure there's no contraindications. It's pretty quick. It's a telehealth.
Any other concerns for her? I think we'll see if heme can schedule her. I assume they will. They're very good. If she does not show up again to an outpatient visit that's at a time that works for her, then I think we should pursue a triage route.
Yeah. My concern is, of course, if she has a preterm delivery and we're already like 28, 29 weeks, we have to give the bone marrow at least 2 to 4 weeks to work to replenish her.
I hear you. Our next patient is Lee Krasinski. She is a 30-year-old G1P 0 at 22 and 1 on this list for a history of a subarachnoid hemorrhage, secondary to a ICA aneurysm. This was in 2022. She, like, neurosurgery is basically said that neuraxial anesthesia would be okay. They said do what is best for mom and baby, quote unquote. We are to avoid extreme spikes in her blood pressure, and her delivery plan is for cesarean. We are planning to have a anesthesia consult or message anesthesia team, just to put this case by them prior to her delivery. And then she has her 3rd trimester visit with us scheduled in November.
This is a patient that I've never met her. She just has a history of a ruptured aneurysm, no current aneurysm.
It's been clipped. Is that right? Yeah.
That's sort of interesting.
This year.
Yeah, I've never met her either.
Okay, it's just interesting that they're recommending C-section. when-
Neurosurgery is recommending it. We told her she was fine for a vaginal delivery.
Yeah, I know I say this all the time in the office, but I'll say it now for teaching, right? A history of an aneurysm or even a current small aneurysm is not a contraindication to Valsalva. Many of our neurosurgeons will say that. Maybe we should invite them to, maybe I'll invite them to teaching and we can all have a conversation about it. Sorry, as I was talking out loud. I think that would be a really good idea.
We're gonna have to show them the evidence too.
Yeah, I'll show them ours, they can show us theirs.
Yeah. Exactly.
And truly, I've said this before, but I think some of the junior fellows haven't listened. If we put together our cases at Jefferson, we would easily have the largest ever, cohort, because our neurosurgeons are so busy. They see so many of these patients, then they come here pregnant after, like in this case, after their episode. We look at literature, not randomized study. It's sort of the cipher. You can read it one way or the other. I agree that in general, vaginal delivery is safe. But we could do it easily here and look at our data. Maybe when they come, we could see how we can collaborate.
I think we're just gonna need a lead from our division, to be honest with you. The neurosurgery department is super duper elegant and research oriented. Vincenzo, I don't know if you know, but they have every patient is on their database.
Yeah.
So they can give us this information. It's just we're gonna need to have hopefully maybe one of the incoming fellows, to take this as a lead project. Yeah, they publish immensely. Pascal is on top of these things.
Yeah.
The next patient is Brianna Lane. She's a 31-year-old. She's a G2P1. She's a 26 and 4. She's here on our list for poorly controlled hypothyroidism. She has post-ablation hypothyroidism in the setting of Graves' disease, and her most recent regimen as of 7 days ago was Synthroid 200 micrograms Monday through Saturday, 100 micrograms on Sunday. She was previously on 200 mics daily. Her TSH as of the 24th is 8.3, up from 0.08 in August. She used to repeat her thyroid function test every 4 weeks. She very recently saw endo in the last week, and she has a follow-up with us on the 13th. And then her plan for fetal monitoring is growth ultrasound every 4 weeks. The next one is in November, and then weekly NSTs at 32 weeks. The next is Tonisha. She's a 40-year-old G11 P5055. She's 29 and 4 on our list for chronic hypertension, non-ischemic cardiomyopathy. For chronic hypertension, she's on Hydral and Coreg. She has been seen by cardio OB. She has cardiomyopathy with a reduced ejection fraction of 40 to 45%. Her BNP was last 77. She has monthly BNPs. The last one was ordered on the 1st. I don't think it's been drawn yet, so October 1st. She's scheduled for a follow-up in cardio OB on the 21st of this month. And she's a return with us next week. She's having serial growth ultrasounds and weekly STs at 32 weeks. The next patient is Aaliyah Mason. She's a 30-year-old. She's a G8P4034. She's at 19 and 3. She's on this list for dichorionic triamniotic triplet pregnancy. She, since we last talked about her, is just getting TDTS checks and MCA Dopplers. Next is today, and her fetal echoes are today. And there's FGR present of babies A and C, and then increased umbilical artery Doppler PI and intermittent absent for baby A, and a normal Doppler for baby B. I don't think I'm missing anything. Oh yeah, she declined genetics or diagnostic genetics and reduction.
Sophie, did I hear you say MCA?
Yep, MCA with twin. Yep.
Hold on. Okay. Which I missed it. Which patient is this now?
The triplet pregnancy.
Mm-hmm.
Okay. I think we were discussing adding MCAs onto all of our twin transfusion screens. Okay.
Okay. Diamnionic. Okay.
The next patient is Rondine McMurrin. She's a 33-year-old G7P4024. She's 33 and 6. She's on this list for a history of PE and pregnancy. She's on therapeutic anticoagulation. It was diagnosed at 11 weeks. She's had a thrombophilia workup sent. She needs additional factors sent after pregnancy. She does not need a transition to heparin. She's seeing JATS later this month. She's seeing us on the 6th for a return visit. I spoke with her yesterday about my study, and she's interested. I think she'd be a good candidate for that. So she'd be on oral anticoagulation, and she does desire to breastfeed. So hopefully she'll be the first consented. The next patient is Gabriella Gerfano. Praise be, she's being induced on Saturday. I have nothing really to add for her. She's such a mess. She's basically not wearing her CGM. She's very intermittently checking her blood sugars. And she's not really checking her blood pressures either. She's supposed to have an NST tomorrow that she's probably not going to come to. And hopefully we see her Saturday with a live and well baby for her induction. Jasmine Palmer on this list, 22-year-old G5, P1122, 26 hyper poorly controlled type 1 diabetes. She is someone we also recently saw. Oh, sorry, no, we were supposed to see her on the 1st. She no-showed. She's scheduled for diabetes clinic on the 14th and a growth ultrasound on the 19th. Her time in range is low, like 25%, as of last month. And she does not really wear her sensor with any kind of consistency, unfortunately. So hopefully we see her later this month. I called her yesterday.
Yeah, she's somebody I'm also going to reach out to again. We got a message from the diabetes educator saying she no-showed her visit last week with her as well. So I'm going to try to call her this afternoon to see what's going on as well.
Yeah, I tried calling her yesterday and I got nothing. Melissa Richards, 41-year-old G4P0030, 21 and 5 on this list for Wolf Parkinson White and SVT. She's had multiple ablations. She's a loop recorder in place. She's seen cardio B and has a follow-up with Dr. Jones on the 21st with us. There's nothing basically to do except if she goes into SVT to follow the pathway with adenosine, beta blocker, vagal maneuvers. She has chronic hypertension that's stable on nithazoline. Janelle Roberts is the next one, 34-year-old G13P7057. She's a 29 and 4. She's on this list for poorly controlled type 2 diabetes. She also had polyhydramnios earlier in pregnancy. Her pre-pregnancy A1C was 13.3. She's on a lot of insulin. I don't have many updates for her except that she had her fetal echo finally on the 25th of November, and that was normal because she has a history of a child with dextrocardia requiring surgeries. I think Dr. Roman, you might have called her, if I'm remembering correctly, or maybe I saw her. I don't know, they're all blending together, but she is on Lantus 2015 and then Lispro 2030.
Yeah, I've been trying to call her. She finally put the CGM back 2 days ago. And I tried call her twice, left her voice message, sent her message because she's having hypoglycemias with this very low
Yeah.
Lantus, but I don't know if she actually made the modifications. Let
She was
me
on
see if she answered back.
2020, and I think you backed off to 2015.
Yeah, surprisingly, she used to be in 80 units. I'm glad I didn't put 80 units back because she's having hypoglycemia with this both AM and PM Lantus. So I sent her a message to lower the Lantus and up with the short-actins. But this is still better than she was, I think, at 10% and now is at 30%. But she didn't answer. And she didn't answer to my message.
Yeah. We will see her next week as well, if she shows up. Mary Rom, I think everyone is familiar with, unfortunately. She had the demise of the monodi twins with the really close cord insertion with the like crazy Dopplers. Does anyone feel strongly about an APLS workup for her? I do not, given that did she have it? Oh, okay, sorry. I feel like there was a clear etiology for why this happened. I don't know, Dr. Bender, we were talking about this in clinic.
Yeah, I wouldn't have felt strongly about it, but it's fine if she had it.
Okay. She's going to see us for a postpartum visit on the 7th of this month.
She also just sent in her FMLA paperwork to our pool, so I'm just going to do that myself so that gets expedited for her.
Thanks, Melissa.
Thanks,
Yeah, of
Melissa.
course.
I'm going to come by this afternoon. I can sign it.
Sounds good. Thank you.
The next patient is Kelsey Rose. She's a 34-year-old G3P0020. She's 18 weeks and 4 days. She's on this list for maternal Stickler syndrome. It was diagnosed in October of last year. She herself has retinal detachment that's been repaired, glaucoma, bilateral hearing loss, and quote unquote weak joints. There's been a lot of messages back and forth with her that I'm just like catching up on. Some of them were with you, Lachey, so feel free to chime in. But she had an early anatomy. Was there a question about a cleft on that, or was that?
No,
It's
it's
not red yet.
It's red.
Okay.
Dr. Al-Khawali read it.
Okay.
It's because of the stickler,
The cleft.
to pay attention to the cleft.
Okay.
There was no cleft.
Okay, great. She's had genetic counseling, and it sounds like she does not want diagnostic testing for the fetus unless her anatomy is abnormal, which is scheduled on the 21st. Given that this also has collagen deficiencies, but not technically the type of collagen that's present in the cervix, We came to a consensus to do a cervical length at the 20-week visit and then again at 23 weeks. And then she's scheduled for both ultrasounds on 28 and 36 weeks. She is going to see Will's eye, the ophthalmologist there, to talk about Valsalva in the setting of her multiple eye issues. Anyone have any questions about her?
Yeah. So I want us to make sure, like as MFM providers, to be better in searching the literature. So I cannot be asking Stephanie to go and look for me and then myself. Has there been any stickler with preterm premature rupture of the membranes? Has there been, patients with short cervix? You understand me? So Stephanie probably spent like an hour or two just on that matter, and it should really be us, the MFM fellows, doing this. So this is just my feedback. We can't just say, okay, we're just going to send for genetics, because I am like you. I have to analyze every single organ system. The same with the eyes. So Stephanie spent maybe another hour or two. So we had, and I spent a lot of time too, trying to look for things like, okay, cataract, the retinal detachment, biosurgeries, all of these things. That's also like MFME, like the retinal changes in any of these disorders, like, do you deliver them vaginally or C-section? So for me, what was interesting, for me, of course, they come to me, we discussed, at length, the disease history, implications for her, further for physical therapy. She's already having some back pain. But this is my feedback, because we're going to be diagnosing and seeing more moms who have genetic disorders. And hopefully, one of my colleagues, maybe Kavisha or Christine will probably can establish like a maternal genetics clinic, right? Like, and that would be one of them. The ADPKD mom would be one of them. But then, as maternal fetal medicine specialists, we really have to dissect the effect of that disease on every organ system. So, all of these things, we can't just depend, okay, it's going to be genetic counseling. So really it doesn't apply, but I'm really proud of the work we've done for her. So I do advise each one of you to read the consult that I signed on her this weekend. Now, I'm referring her to do, I have a phone call. Hopefully Alexa is helping me to, Alexa to connect me with the physician who reads fetal MRI. And the reason is because I saw this patient on ultrasound for the first time, and it was like a party for us seeing each other. So first of all, when I look at this patient, I know we have to go. We have a lecture at 11. Maybe I should stop.
Yeah, and
Yeah,
we have a Julie, I
okay.
think, has
Yeah, Julie.
signed
Okay.
on, and
Okay.
thank
Yeah.
you, Julie, for signing on.
Yeah, so basically I do have to stop. I examined her. She had a huge cleft palate, not the usual hard one we see, all the way that goes to the uvula. And she did mention how difficult it is for her. She had difficulties eating and breathing as a child. So that is the reason I am thinking of doing an MRI. With that said, thank you, everyone.
Thank you, Dr. Alquali.
Of course, thank you.
Sophie, if we can finish the list quickly, so that we
Can
can
we
move
just
to
talk
the.
about the scleroderma
Okay,
lady? I
thank
feel
you.
like there's
Go
been
ahead.
some conversation about starting meds for her, and then we can be done maybe.
She is a 33-year-old UNP0. She's 18 weeks and or she's 19 and 0 today. She's scleroderma with restricted lung disease. I've never met her, but she has Raynaud's, GERD, skin tightness, sclerodactyly. She has been coordinated with pulmonology. Dr. How do I pronounce his name? It's just she has this gas transfer. That's right. Okay. Sorry. So she's had discussions surrounding starting immunosuppression with pulmonology and rheumatology, and I believe is it Pulmaroo? Room is going to discuss her at their division meeting to see what they would recommend in terms of medication initiation. That's, I think, the TLDR. And that is not happening until later this month. So we will know. I'm in a chain with them, so I could reach out after their division meeting. And Jane, you agree?
Thanks, Sophie.
Thanks, Sophie. Again, we have a treat today. Thanks, Julie Moldenauer, for being with us from the Moors. I think
Thanks for having me.
Yeah, you're going to talk about monochronic twin complications, a topic we talk about all the time. We just presented a few monodi twins, in fact. So go ahead if you want to share your screen or whatever you want to do. We have a bunch of attendings, fellows, students, residents, etc., listening in both in person and
All right, sounds good. Let me
Zoom.
see if I can get this up and running.
Perfect.
And totally want it to be interactive, so you all please feel free. Can you see this? Why is this not?
Yep.
Okay. I can't see you guys because I'm in presenter mode, so please just feel free to interrupt and ask questions. And again, really want it to be interactive. And I hope that this is actually useful, practical information that I'm going to share. So I have no disclosures of the fact that I'm obsessed with my dogs because my kids are too old now. So I keep buying them Halloween costumes. So there's that. I really just want to highlight all of the common complications that we can see with monochorionic twins, largely twin, selective growth restriction, TAPS, TRAP, the whole 9 yards, and then talk about what are management plans, how do we monitor them, and then really like if they have an intervention, what is the best way to monitor them, how to monitor them going forward, what are the complications we want to look out for, all the things essentially. We're kind of obsessed with twins in our culture. They're in art, they're everywhere, especially, you know, identical twins, which is, you know, kind of the bane of existence for all of us MFM folks because we think that they're really scary, actually, right? This is an interesting picture. This came from like the 1600s. So this is from an aristocratic family. And clearly, this set of twins probably had like twin transfusion syndrome or TAPS or something, because you can see that one is very ghastly white and the other one's very red and ruddy looking. And so we know that these complications have been happening, you know, forever since the dawn of time, but it's really only been in the last 30 years that we've given them names and potential interventions and have really acknowledged them, and they become a widespread part of our practice of MFM. And we see, you know, monochorionic twinning even in nature. This is another one of those things that every time I see these little conjoined flowers or strawberries or carrots or whatever, I take pictures of them. So I've got like a whole collection of natural conjoined twins. But this is what happens, right? And the reason that this happens, it all depends on when that fertilized egg separates. You guys, I know that I'm preaching to the choir and you guys all know this, but the later that that egg separates, the more complicated these twins end up being for us and the more surveillance and worry that we have for them. And so specifically what we're going to talk about today are those monochorionic twins. I'm going to put a little bit of flavor about interventions, a little bit in the setting of monoamniotic twins because they just offer us a little bit higher degree of complication rates. Like for laser with twin, if they're monoamniotic, it does happen more rarely with monoamniotic twins, but particularly if we're going to talk about like a selective reduction procedure with monoamniotic twins, it does become a little bit different. So nailing the amnioticity is key when we're early on evaluating these twins. Because sometimes what happens, especially with twin, is we may think that it's monoamniotic because, you know, it just looks like one giant sac in there when it could be potentially diamniotic, or we think it's diamniotic, but it's one twin that just might be a limb body wall, because I've seen all variations on these things. Again, our culture is obsessed. You know, Ann Geddes took pictures of twins in cute little positions. There was the double mint twins, all of these sorts of things, right? But this is what it's like when you're an MFM and you're actually caring for these patients in your practice. what are the things that we're talking about? So if you look at the grand perspective of the common complications of monochorionic twins, the bane of that whole problem is this right here. So this is a picture of the surface of a placenta. This is a blood vessel from one twin. This is a blood vessel from the co-twin. And here you can see this anastomosis. So this is what leads down the trail for all of the issues we worry about. And I know we spend a lot of time talking about twin-twin, but selective fetal growth restriction is actually more common than twin-twin. So if you look at selective growth restriction, you know, that happens in about 15 to 25% of monochorionic twins. Twin-twin is about 10 to 15% of the time. And then things like TAPS or TRAP are far less common. And again, the whole reason that we see this happening is because of these anastomoses. They can be vein-vein, they can be artery-vein, they can be artery-artery. And on top of the anastomoses, these twins just don't share the placenta equally. Most of the time, somebody has a bigger share, somebody has a smaller share. Generally, they tend to figure it out and keep things well balanced, and they get along fine during the pregnancy. But when they don't, that's when we see these complications we worry about. And so, again, I know you guys already know all this, but it's really important to determine the chorionicity. You know, we can use the gender to some degree to help us decide, you know, are there multiple placental sites? Do they look like there's one? Thin or thick membranes, the lambda sign. And then it's really important to do a thorough evaluation of the anatomy of both twins, because we want to make sure that they're not discordants for any structural difference or underlying syndromic diagnoses. And then sometimes making a determination about an acardiac twin can be complicated, because sometimes they can be fairly well formed, and that heart tube can actually have a little, you know, pulsatility to it or a little beat to it, and may come across like it's a really complex cardiac problem as opposed to a form of a trap, because I've seen sort of every variation on those as well. You guys know this early on, you know, and even a little bit in the second trimester when we're looking to nail the chorionicity. If you see the lambda sign, you know, this is telling you that you've got dichorionic twins on your hands, because you've got this little chunk of placenta kind of running up in that membrane between the two, versus a T sign where it's a much thinner membrane. It looks like a much straighter sort of entry of that membrane into the placental surface. And these are pretty sensitive and specific when you're trying to determine your chorionicity. And then why is it that we spend so much time talking about monochorionic twins? Well, again, the whole bane of the problem is the fact that they have these vascular anastomoses. And so in the situation where one becomes very ill, has poor flow, or even in the setting of a demise, there's pretty significant risk for the survivor. And so the risk for neurologic sequelae in the setting of monochorionic twins where one has resulted in a demise, in the literature, it's really anywhere between 10 and 30%. So it's not a small risk. And not only can they have neurologic injury or intracranial insults, but we can also see, you know, renal damage. We can see limb necrosis, you know, sort of a whole wide spectrum of this. Once you've had co-twin demise, there's really no benefit to an immediate delivery. And so, you know, if you're following a set of twins serially, they come into the office 1 week, everybody's looking okay, the Dopplers are reasonably stable. They come in, you know, a couple of days later, a week later, and one has passed away. There's no benefit to doing an early delivery at, say, 28 or 30 weeks. At that point in time, you know, you really should try to get the benefit of a term delivery for the survivor. One thing that you could offer up is, you know, continued evaluation of the intracranial structures, just to make sure that there's no obvious, you know, sequelae from like a large bleed or something like that. And, you know, we have had parents that have opted when that happens to go, you know, to other states for a late termination in the case of a really bad vascular accident that happens to the brain. This is a case where we saw a patient and was being followed and had a co-twin demise, and ventricles on both babies were completely normal before it happened. And then after the co-twin demise, you can see there's pretty significant ventriculomegaly in the survivor. and just layering blood products all along the ventricles. And that kiddo took a pretty significant hit. You can also see the placenta just kind of looks funky even on the MRI, because it got very plethoric and a lot of backflow and congestion from the co-twin demise. And if you look at a comparison of dichorionic versus monochorionic twins, overall outcomes are much more favorable. I always use the analogy to patients where it's kind of like having, kids, they all live in the same house, but dichorionic twins each have their own bedroom, and monochorionic twins, are sharing a bedroom. And so they can cause a lot more trouble. And so, every factor kind of has higher stakes when you have monochorionic twins. So not only preterm delivery, the risk for, abnormal cranial imaging, obviously the co-twin demise rate is much higher, but, neurodevelopmental morbidity is much higher when you have monochorionic twins. So what are therapies that we potentially have available in these settings? So, they're vast and sometimes there's just not a right answer, particularly with TAPS. I think TAPS is probably the one diagnosis, and selective growth restriction, particularly type 3. Those two diagnoses, I think, really give us pause because there's not a clear, correct answer in management. And so, conservative management and observation is always a choice, and it can be one of the methods that for families, they feel better just waiting and letting nature take its course. If there's a clear benefit to laser or a selective reduction, then I think that becomes an obvious answer to families and it's easier for them to proceed. I think that when there's ambiguity as far as like long-term outcome, that's when it makes it really difficult. And in monochorionic twins, there's not, like I said, always a perfect answer. I know we talk a lot in fetal intervention about open fetal procedures, really having a risk factor, but pretty much everything we do has a risk factor. And so if you look at even just with these minimally invasive procedures, so like the equipment that's used. So for example, like an RFA for selective record occlusion with a radiofrequency ablation. This is really a 17 gauge needle for all intents and purposes. So it's pretty narrow. For shunts, it's a couple millimeters. Fetoscopy, the same thing, a couple millimeters. And these are all ultrasound guided procedures. But if you look back at the literature, pretty much every complication under the sun has even been reported with minimally invasive procedures. And so Adelina Sacco did a really nice paper a number of years ago where she looked at any kind of complications with both minimally invasive and open fetal procedures. But the likelihood with a minimally invasive procedure to have any kind of complication, it's not 0, it's still 6%. And if you looked at severe maternal complications, it's just under 2%. There weren't any maternal deaths in her review of the 9,400 patients. But again, I just want to make people aware that sometimes I feel like we think that, oh, it's minimally invasive, this really isn't a big deal. Most likely we're going to have a good outcome, but we still have to counsel patients to include all of the above as potential, risk factors. Mike Zareski did a great case report. And again, I know that we really harp on this with open fetal cases, but they actually had a patient, they could see this on ultrasound, and they could see like a little bubble of basically membranes and amniotic fluid when they were kept scanning the patient. And they realized that after they had done the laser, the port that went in for entry never really healed. And so that little bubble actually was an open spot in the myometrium where the membranes and the fluid were kind of flowing through. And so, uterine defects can happen even after minimally invasive procedures. Very unlikely, but still a possibility. I would be remiss, especially in the group of MFMs, to not talk about mirror syndrome, because we do see this with complicated monochorionic twins. Particularly the times that I've seen it have been with severe, like stage 4 twin, and then really sick TAPS kiddos. And so, taking care of not only the fetuses, but making sure that mom is okay, asking about, any kind of symptomatology. If you have hydropic babies is super important. Because the symptoms of MIR are very much a wide spectrum. Sometimes you might have moms that just continue to have like this, I don't feel good, I just don't feel myself, this sort of thing. And that can be one of the big caution signs to say, oh, I need to take a closer look at these twins. Maybe there's more going on here. Because this can be a really major problem for mom. There are case reports out there, freely admit it. We have stage 4 twin, mom is borderline mirror syndrome. You do the laser, the kids get better, mom gets better, but sometimes mom doesn't get better after the fetal intervention, and she may still need to actually be delivered regardless. Because if you look at it, these moms not uncommonly end up in an ICU. And about 1 in every 5 women that get Muir syndrome ends up with a severe complication and an ICU stay. And the symptoms are very much similar to, preeclampsia, sometimes help when they're, a little bit ambiguous flu-like type symptoms. But fetal loss rates when you have overt Muir syndrome are pretty high, and probably about somewhere between 1 in 3-ish babies are lost either from severe prematurity or they pass away. And twin complications are not an uncommon cause, which is what I just wanted to highlight here. So really anywhere between about 5-6% up to about 20% in the literature as far as Muir syndrome. All right, so let's talk about surveillance. The SMFM consult series, and I just sent this to Carrie because I want to make sure that you guys all have a copy of the recent consult series that Russ Miller and Gina Miller put together. But really, where we're at right now with this is at about 16 weeks, every 2 weeks. And what you're looking at is the deepest pocket in each sac, whether or not both babies have a bladder, and then potentially umbilical artery Dopplers, right? So this is kind of pretty much where we're at with standard of care for surveillance of monochorionic twins. As the conduit or the communication folks with neonatology, I think the biggest thing for us to communicate whenever we're taking care of monochorionic twins is that these are really high risk for prematurity. And so neonatologist needs to be ready and prepared for all of that. And if the babies, haven't resolved whatever their ailment is related to their monochorionicity, so if they're TAPS or they're twin, and they get treated, great if all their parameters have normalized prior to birth. But if they haven't, those kiddos, in addition to being premature, are also going to have a lot of manifestations that, those neonatologists are going to have to manage their cardiac overload or their severe anemia or a poor cardiac pumping function, all of the things. And so they just need to be aware of what the underlying diagnosis is so that they can really anticipate how to manage these neonates. You all know that the hallmark for twin is polyhydramnios, oligohydramnios. And I know sometimes the patients are a little bit, on the fence. What do we think? Is she going to develop this? One fluid looks like it's sort of like creeping up a little bit. One looks like it's going down a little bit. But when it happens and it's legit, you will not miss it. It will the medical student can recognize it from across the room. Mom walks in, she's walking like a penguin because she's miserable. Her belly got really big, really fast, a lot of times like in less than a week or two type of thing. Most often it comes on pretty full force within a couple of, 2 to 3-ish weeks type of situation. So when it really happens, no doubt that you'll nail the diagnosis. Other things to kind of look at if you're thinking that it's looking twinny, right? So cardiac function, does the heart look thickened? Do the heart walls look thick? Do you have a nice good squeeze to that heart, or is it kind of looking a little, like it's fluttery almost? The liver will start to look congested. So, that starry sky type of pattern, you notice that it just kind of looks really big. It might catch your eye. Other things that you want to make sure of if you think that one of the twins, doesn't have fluid, the other thing you want to check is make sure they have kidneys. Is this really twin, or does that baby not have fluid because that baby has renal agenesis? So just make sure you slap the Doppler on and that you demonstrate renal flow. And then always, if you're worried about twin, take a look at the cervix, because these cervices can get really, really short, really, really fast, especially when these moms are carrying around, this magnanimous amount of fluid in that recipient sac. And so everybody knows the Quintero staging system. This has been around for, 25 plus years at this point. And this is the criteria that is really out there. This is what everyone is using. This is a nice, easily translatable diagnostic criteria. Right now we're not using like the Tay index, we're not using cardiac scores, we're not using this, we're not using that, even though those things can help us. But I think that for the most part, making a diagnosis and making a referral, for intervention really relies on the Quintero staging. And so again, using this criteria, it's about 10 to 15% of the time that we'll diagnose monochorionic twins with twin-twin. And so using that definition of polyhydramnios with a deepest pocket over 8 centimeters, an oligo of less than 2 centimeters, stage 2, when you don't have a visible or a cycling bladder in your donor. Stage 3 is when you have abnormal Doppler studies. And I know there's a lot of back and forth between a lot of different, of our societies as far as, do we just do umbilical artery Dopplers? Do we do umbilical Dopplers? Do we do MCAs? Do we do ductus? I would really suggest that if you're worried at all, that you do, all of the Dopplers, do the umbilical artery, do the umbilical vein, you're going to do the ductus venosus, because that's really going to give you a full picture of where you're at in staging. And then obviously stage 4 is if you see ascites or hydrops in either twin. And then stage 5, which of course we're trying to avoid, is death of one or both twins. And then Dr. Bergello's paper, because I always use this as a very stark contrast of just how far we've come in the last, during my career, I guess, is that when we would expectantly manage these, or we wouldn't even make a diagnosis of these, if you're thinking about what the likelihood of survival when you diagnose twin less than 28 weeks, it was really only about 20 to 30 or 10 to 30%. And now with, the intervention of, ability to perform laser, we're actually flip that statistic around. And so when you diagnose mid-trimester twin, we have survival rates, that are now 70 to 90%. And so to me, this is, a huge impact for the long-term outcome for these kiddos.
Thank you, Julie.
That's one of my favorite slides. I always talk to patients whenever I give this lecture. I always use that slide. So why did we land on laser, right? So this is another question that people ask. Well, could we do something a little less invasive? That's just a needle procedure. You could do it in outpatient. You could do it in the ultrasound unit. And so, there were a couple attempts to look at, amnio reduction and septostomy as treatment modalities, again, because these minimally invasive, thought to be less risk involved. But in this first trial by Ken Moise, outcomes weren't fantastic for either of these minimally invasive, and it was 50-50 essentially if you were going to get dual survivorship. And so clearly that's not really cutting the mustard, because we want to get better than that. We want to do better, right? And so what about doing laser? This does involve a trip to the operating room. We do give a little bit of anesthetic with it. It's a little bit of IV sedation. Some people do it under epidural. You can do it even with just local. There are people that do it that way as well. It's nice to have mom a little bit anesthetized so that she can relax, because a lot of times when they have all that fluid, it's very hard for them to lay flat for any kind of period of time. But the whole concept with the laser is that we are going to go in with the scope, and we're actually going to look at the surface of the placenta, and anywhere that we see that there's an anastomosis, we're going to laser coagulate that anastomosis. So you're basically welding the vessel shut between the two, and you're functionally separating the two sides of the placenta. And outcomes with laser in the initial trials were significantly improved. So we had dual survivors that, went above 70% and singleton survivors above 80%. And so, everybody kind of started to get on board that, maybe this is going to be the better way for us to go to treat twin. And then the Eurofetus trial, which is a nice randomized trial that looked at laser versus amnio reduction, kind of proved all of these points. The gestational age at delivery was much higher after laser. Survival of at least one baby was much higher. And the risk for major neurologic sequelae was significantly improved with laser. And why is that? Well, because even if you lost one of the twins afterwards, in theory, we should have basically functionally separated them from a vascular standpoint. So if one passed away, that back and forth profound hypotension that happens when the co-twin or the survivor can bleed into the dead twin, much less likely to happen in that instance. And so this is really kind of where the concept that laser is the treatment of choice for twin came to be sort of the accepted standard of care. And so who really is a candidate for laser? And we'll talk about stage 1 in a second, but really stage 2, 3, and 4. Hands down, that's what the current recommendation is. This is actually what a placenta looks like after a laser when mom has delivered, and then the dye injection studies are performed on the placenta. So you use 2 different colors for each baby, and so you inject, down the artery one color, down or arteries down one color, down the vein one color. Same thing on the co-twin. And then see where it kind of almost looks like scabs or like a different color here. These are all the different areas that were lasered here that basically show the separation. This placenta is actually pretty well balanced as I'm sitting here looking at it. I haven't looked at this in a long time, but it's pretty well balanced. So one baby doesn't have some huge proportion compared to the co-twin. And see how one of these is like way over on the edge of the placenta? This is not uncommon to see that one of the twins tends to have sort of, a very eccentric placement of their cord. And so again, when we are functionally separating these shares of the placenta, and what the video is showing you is a direct look at the surface of the placenta, tracing the vessel from one cord insertion, going down, 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 down. And you can see that little green light, that's the laser fiber just kind of showing through. But now you can see like, okay, what's going on here? There is a bunch of blood vessels coming from the other direction as well. Because what you should in theory see, here's the fiber coming down. These are where the connections are. The laser is going to fire, and then what it's going to kind of just look like is a blanching of the vessels. And that'll kind of scab over and scar over. But what it should do is stop that vascular connection, the blood flow between the two. And so when we're looking at the surface of the placenta, you should see an artery and a vein always paired together coming, from each baby. And so as you start from the cord insertion site, you just keep tracing all the blood vessels, and everywhere that you stop seeing an artery and a vein traveling together, and one vessel kind of goes rogue in the other direction, or sometimes both of them go rogue and you see them meet up with an artery and vein from the other twin, that's where the connection is, and that's when you want to fire. So, there's a technique, and I'm not going to get into it because we don't have enough time in an hour, but you can use selective methods where you're, kind of just going like, which I'm showing you here, is we're selectively choosing all the anastomoses, and where we actually definitively see them, that's where we're going to fire the laser. But then you can also use the Solomon technique, where you basically just kind of find the equator and you go down the whole thing straight across. And so there's a little bit of evidence that probably Solomon may decrease your risk for residual anastomoses, but neither method is perfect. And I really think that if you can see all the vessels and you can see them well, doing a selective procedure is probably the right way to go. If you're ever worried that you don't have good enough visualization to create a nice, clear, annihilation of that equator or risk for, continued anastomoses, you for sure want to use more of a Solomon technique in those instances. These are not easy cases, especially when you have an anterior placenta or a small window. And so there is 100% a learning curve associated with competency for laser ablation of anastomoses. And so, a couple of really nice papers that came out, really it looks like probably right around somewhere between about 25 to 30 procedures is kind of when you hit that sweet spot that you can have reproducible outcomes. And so what about stage 1? So, there's a lot of back and forth literature a number of years ago as far as like, what do we do with stage 1? Because they're really not sick enough to run in and run the risk of doing a procedure for those twins, versus are there a subset of stage 1 twins that we should do the procedure for? Because if you look, what's the likelihood of progression? What was out there was anywhere between, 9 to 10%, all the way up to 60% risk for progression. And so, this is when Eve's group and Julian Sterneman did the RCT for stage 1 twin. And this really has now kind of become our guiding platform for the management of stage 1 twin. And what the trial really showed, and this was a big international randomized trial looking at stage 1 twin that all met the appropriate criteria to say, do we take them directly to laser, or do we monitor them and use expectant management until we see other signs of why they should actually move forward with the laser? And so more or less what happened is that there was no immediate benefit to moving straight forward to laser. But if they did progress, then absolutely that's when we should do it. And so who is it for stage 1 that we're doing laser for right off the bat? So if they have any other findings, so if on those, Tay index or cardiac scoring systems, if we see significant echocardiographic changes, if mom has a really short cervix, if her symptoms from her polyhydramnios, is she sleeping at night? Is she nauseated? Can she eat food? Is she contracting like crazy? Is her polyhydramnios just going boom, 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 boom? Is she like miserable? Those are all reasons for stage 1 to jump straight to laser as opposed to just weekly, or twice weekly monitoring situation. So post-operatively, what do we do? So I think most of us in the fetal world recommend that mom stays on bed rest, pretty tightly monitored for about a week after the procedure. And then about a week later, also do ultrasound and echocardiogram. Because sometimes, and why I think it's important to also do the echo, is that we can see some acute cardiac changes that might show up on an echo, especially if you're going to get like reversal of twin or something like that, that may not necessarily show up if you're not looking for some of the little small signs. And you're looking for other complications, right? So like, is there membrane separation? Is the placenta look like there's a subchorionic, clot that has formed? Are the Dopplers stable? By a week out, really, your fluid levels should start to stabilize. They may not be completely equal, but, your donor sac, you should see bladders in both kiddos. You should see a decent amount of fluid in your donor. Your recipient, deepest pocket should stabilize, all those sorts of things. And I always go and get a quick look at both babies' heads. I don't have to spend tons of time, but I want to see, am I worried that there's ventriculomegaly? Does it look like there's, layering blood products? Because sometimes if they're really sick, especially, like these stage 3 and stage 4, that might have poor cardiac function going into the laser, we can sometimes see bad things happen even just after a laser. So it's important to take a quick look. I already showed you a picture. This is one dye injection study afterwards where we're assessing, and you can, nicely see there doesn't appear to be any residual anastomoses. Everybody kind of stayed on their side of the ballpark. But what happens if they don't? You can see here in this nice one, oh, look at this little yellow thing kind of coming over into the wrong place. Yep, there's a little residual anastomosis that was missed. And these are the type of things that will cause your post-laser taps. These are also the things that if one of the twins gets really sick and does pass away after a laser, this is what can cause, that neurologic morbidity and a co-twin demise as well. The rates of residual anastomoses vary, depending on the group who's doing the reporting. Do they do dye injections after all their cases, all those sorts of things. And so one of the early studies said that, we have residual anastomoses rates after laser of up to, 33%. That's pretty significant residual. I think that probably, this was one of the earlier studies from 2007. That rate has really been reduced with some of these other methods that we're using, like the selective lasering or solemnization type of thing. But again, outcomes are bad if you have anastomoses, residual anastomoses. So there's a much higher rate of singleton IUFDs or double IUFDs when you do have residual anastomoses, which is really important for anybody who's doing lasers to have sort of an ongoing, quality assessment process in place to make sure that your anastomosis, residual anastomoses rate is reasonable. probably what's more reasonable as opposed to, you know, having 30% is probably like in that 5 to 10% range. And that's pretty much where folks are now in 2025. The equipment's better too. You know, when we first started doing these, you know, it was pretty grainy. You may not see it as well, but the equipment has come a long way. So what are things we worry about after laser? We kind of talked about some of these. We worry about membrane separation and PPROM, bleeding, choreo, you know, the co-twin demise, and residual anastomoses. This is actually what it looks like if someone has a whole lot of bleeding, you know, after the laser, particularly into the amniotic space, and you have one of these complications that develops and you have to go back in and re-laser. This is what the fluid looks like with all the blood in it. This one that looks like, you know, it looks kind of like coffee, and it's super dark, and it's like trying to visualize and laser basically through, you know, like a latte. And so you have to do an amnio exchange because you want it to look like this or you can't see what you're doing. And here's a nice picture of membrane separation. And I just put a couple pictures of it because it can look very different separation to separation. So you can see here, these are pretty big. They're floating around. You can kind of even see the inner twin floating. So there's fluid on both sides of the sac. And then it also separated from the side wall of the uterus. And this one's a little bit more defined, and it's really only in one corner of the uterus. The baby's kind of pushed up against it. It's a little bit harder to see. And so you really have to take a sweep all the way around that uterus after any kind of fetal intervention just to make sure that there's none of this happening anywhere. And what we do know is that if you do see membrane separation after a laser, that significantly increases the likelihood that you're going to have PPROM and you're going to have a pretty preterm delivery. And so here's, you know, a nice paper that Ramesh Papana did when he looked at cases of membrane separation versus no membrane separation. I mean, you can see here, you know, the likelihood that you're going to have PPROM is pretty significant compared to if you don't have membrane separation. The interval from the procedure to delivery, you know, is a lot lower with membrane separation, earlier preterm delivery, and then survival rate is going to be lower as well. And so it's really important that if we notice this to counsel the family, you know, counsel mom, this is what you're at risk for, and monitor closely. And so, you know, the new SMFM guidelines say that follow-up after laser, you know, after that first week is really weekly up until about 6 weeks, provided that everything is stable and that you see signs of resolution of the twin, and then you can space those visits out. You know, some of us still follow them weekly until delivery. The goal is to try to get them as close to term as you possibly can get them. And per the new SMFM guidelines, you know, really 34 to 36 weeks is the goal, which I think is a glamorous goal, and I hope that we can get them all that far. Can we predict demise? No, there's not any great, and I only put this up here because it depends on what study you read. There's no way to predict who of the two, donor versus recipient. There are some signs, but I think that this is why it's really important that we follow them so closely afterwards. And then what about the long-term neurologic outcome? I still stole this from the old SMFM guidelines because I think this is a really good table. But if you look at the long-term neurologic outcome of monochorionic twins treated with laser specifically for twin. So if it's growth restriction or other things, these numbers are different. But really, this range is anywhere from about, you know, 5 to close to 20%, depending on the study that you read. And so I don't think it's minor. I think these kiddos should be followed afterwards. You know, at least ages and stages questionnaires for the parents. It'd be nice if they could all get some kind of formal testing, but the risk is not zero. And I think that we just need to make sure that we counsel parents about this. And then what else should we look for, you know, outside of, you know, neurodevelopmental delay? You know, we should also be looking at their cardiovascular function. You know, some of them will have overt, you know, cardiac disease. They can also develop, you know, some of these, you know, outflow tract obstructions just when they are getting severe, you know, cardiomegaly with their twin. But we should be doing echoes on all these kids in the first year of life. And so I just want to make sure that we talk about that. Again, I just talked about RVOT obstruction, but it is significantly higher. And so we should be making sure that we're making this recommendations to parents as well. Yeah. So any major questions or anything about twin twin? I know I went through a whole ton very quickly, but
Hi, Julie. Thank you so much for coming today. This is Huda, the maternal fetal medicine
hi.
geneticist, and we're very much excited you are at Nemours. So we're going to be working together a lot.
Sounds good to me.
Yeah, absolutely. So Nemours is our preferred place to send patients for at Jefferson. So my question is, you have the demise of one twin, monochorionic. How many weeks you think you have to wait to get the MRI if the mom is
Ah,
interested in cerebral palsy? And at what gestational age? Like, what's the earliest, like
that's a great question. Yeah. So this is one of those hard learned lessons.
Mhm.
So early in my career, when we would have a co-twin demise, we would do the MRI right away. And I think we got some false assurances from that because these fetal brains don't quickly show you the level of devastation that can happen. It does take them a few weeks.
Mhm.
So probably waiting about 3 to 4 weeks after an event is enough time to give you any indication if something is changing. Um, yeah, I'll just tell a story. So we had the situation happen, and she came back, I don't know, 2 or 3 days after laser, had a co-twin demise. So the beginning of the next week, we sent her for an MRI, and at that time, things actually looked okay. Gave her a lot of reassurance, blah blah blah. She came back, what a couple weeks later for an ultrasound, and intracranial findings were a hot mess. And clearly, we had just done the MRI way too soon. And so, waiting at least 3 to 4 weeks is really kind of the sweet spot in order to get as much information as possible.
Do you have any particular gestational age? Let's say the demise happened at 20 weeks. So is it okay to do it at 24 weeks? Like,
Yeah. Yeah.
the MI would be good. But if someone, let's say, because we had a patient who had a demise at 14 weeks, like what would be the ideal age to wait on someone like that? And she was also interested in information. So we sent her at around 22 weeks.
Yeah, that's a great question too. So when you're looking at all the neurologic structures, if you do the MRIs at 18 weeks, most of the neuroradiologists will come back with sort of one of those hedgy reads
Yeah,
about, not all the structures are fully formed, all that kind of stuff, right?
yeah,
So
yeah,
their preference so that they can distinctively say this looks normal versus, this is developmental, those sorts of things is right around 22 weeks.
yeah,
So at least 20 weeks, and 22 weeks is really the preference.
yeah. That's great. So I think we did call with the MRI center. So yeah, we got that. But it's always interesting, to evaluate like what's the evidence for that and how to better counsel our patients. Yeah,
It's
that's
hard.
amazing.
Yeah. Yeah.
It's very, very hard. Absolutely. We are so excited that you came and lectured to us today.
Oh, well, me too. I have more. I just want to take a
Yeah,
break after
let me
this.
jump in as well.
Yeah.
Sorry to put you on the spot, Julie. Do you, when do you think you'll be ready to do laser at Nemours?
Well, we ordered all the equipment.
And there you go.
So the equipment is on its way in. Um, Hopefully by like January or so.
Great.
Yeah.
That's great. I know that Eric, again, you already presented. He's been busy seeing lots of prenatal cases and getting ready to do all kinds of stuff. But that will probably be the first thing will be ready, right? Laser for twin to twin.
Yeah. Yep.
Yeah, that's
Yeah, he's
great.
already done a few like amnio reductions and some
Yeah.
chest taps and kind of small outpatient type things. So we're keeping him plenty busy.
Good.
And Julie, I want to go back to the stage one twin
Yeah.
tension. So I know when you were at CHOP, like you and Nahla would depend on diastolic dysfunction by the echo, and then you would say, okay, what is the component that I would say, okay, go ahead, we should laser this. And I'm sorry if I'm taking so much time to ask all of these questions. Can you just share with the fellows, like just in like few sentences, what are you looking for when you do the echo to make the decision? We're going to laser this patient, even though it's only polyhydramnios, oligohydramnios. In other words, it doesn't fit Quintero staging. It doesn't belong to 2, 3, 4.
Yep.
Yeah,
Yep.
yeah. Go ahead.
Yeah. I mean, so you want to, like, does the heart look really thick? Is there a lot of, regurgitation? That's another key component
Mhm.
too. Are you also seeing, it's also you clearly when these babies are super sick, you guys can even see this on a regular ultrasound. Like, is that nice cardiac squeeze there, or does it almost
Mhm.
just look like it's a lazy little squeeze? It's like type of
Mhm.
thing. They look like really just poor function. And those are the big things. Is it a really thick walls, particularly the ventricles, you're going to see.
Hypokinetic. Yeah.
Yeah, very hypokinetic. And then also,
Mhm.
like, is the whole size of the heart look like it's gotten much larger
Gotcha.
type of thing? So you're going
Okay.
to see like some significant cardiomegaly and then the valvular regurgitation. All of those
Okay.
things tell you that like we're heading in the wrong direction.
Okay. So this is good criteria for the fellows, thickened
No, yeah,
walls,
yeah.
enlarged, and then hypokinetic. And then interestingly, you mentioned a short cervix also.
Mm.
You jump. So if I have oligohydramnios, polyhydramnios with a short cervix, you also jump on doing the laser also. And is this because you don't want to wait longer? It's because you're trying to prevent preterm birth. Obviously, you probably stitch them or want us to stitch them also.
Yeah, I mean, sometimes there's mixed data as far as like putting the cerclage in. Some people have
Mm-hmm.
had great success, some other groups haven't.
Mm-hmm.
I tend to probably be a little less aggressive with the cerclage, but do a reasonable amnio reduction. And
Mm-hmm.
then, Indocin is my favorite friend. So I will
Yes.
like do a little Indocin with it because it also help you keep your fluid levels down, afterwards and keep that polyhydramnios to hopefully get that sorted out quicker on the faster end of recovery type of thing. But yeah, that usually is how I approach it is, fairly aggressive amnio reduction and then Indocin. And then Tim Crumbleholm uses Procardia
Mm-hmm.
because he really believes that it helps with the cardiac function. I don't know that it is completely proven out, let's just say it that way. But some groups also do aggressive amnio reduction and then, Procardia on top of it.
Okay, great.
Julie, this was really, really helpful. You have a lot more slides. We'll be in touch so we can
Yeah, I can do the second
schedule.
half. There's a lot to fit in. So
You don't
yeah.
mind,
Yeah, absolutely.
and have time. As you can see, the fellows here around the room are eager, and we'll be in touch soon to get the second half and the third half and all of that.
No,
Yeah.
absolutely. Love to. Happy to.
Thanks. Anything
Have a
else? No, you good?
No, I think we're good. And Julie, before you go, we don't have data on the short cervix, amnioreduction, Anderson so far, correct, dear?
Mm-mm.
Stitch, no stitch. Okay.
Yeah.
Okay.
Yeah, there's not really great data on any of them.
Yeah,
So yeah.
personal experience. Absolutely. Great. Thank you
Yep.
so
Yep.
much.
All right. Thanks you
Happy
all.
lunch,
Have a great day.
everyone.
All right.
Thanks for
Thank you.
coming. Bye-bye.